Perfect. Good morning. How is everybody today? Very good. Very good. Okay, so today is class 2. We have a lot of stuff to go over. We're going to cover gloves, infection control, pulse, and dressing resident with a weak arm. I also think we have a range of motion in here today that I'm going to try to get to. If we don't, sometimes I'm not able to get to that skill. If we don't, we push it off to a later skill. It's not a big deal. I've got a little more time at the end. At the beginning of the program, the first 2 weeks, there's so much to get into each class period. All right, so your homework from last class was chapter 1. You should have read chapter 1 in your yellow book and taken the test on page 181 in your white book. If you did not get to it, it's not a big deal. When I call your name, just say pass, and I'll ask you again next class, okay? If you did get to it, when I call your name, please let me know how many you missed. So you should have graded it with page 201 in the white book. Let me know how many you missed, or there's a grading scale there at the very bottom, and it tells you if you missed 1, you get a 95. If you missed 2, you get a 90. Each one's worth 5 points. So either tell me your score or tell me how many you missed, and I'll do the conversions. Veronica? All 3 wrong. Okay, thank you. Deslin? 1. Thank you. Hannah? I think 1. 1. Thank you. Bianca? Sylvia? Chelsea? Nevaeh? Cynthia? I missed 4. 4? Thank you. Anthony? I missed 2. Thank you. All right, those of you who missed questions, do you understand why the right answer is the right answer? Is there anything you need me to go over with you? Any terms, any concepts, anything?
Okay, so I missed question 4, and it says a resident's protected health information includes. I chose diagnosis and treatment plan. No, wait, it includes resident's name, resident's address, and
Right. So everything about that particular person that can be used to identify them is protected. So things like their name, their address, like I can't be in a hallway saying, hey, Mrs. McGillicuddy had this, because that's protected. So name, address, phone number, also their treatment. If a neighbor comes in to visit a patient and says, hey, what does she have going on today? Does she have surgery? What were her labs? We're not allowed to give that information. That's all protected. So that's part of the treatment plan. It's protected. The patient gets to control their information. They get to decide who can have access to it and who can't. And that's really the whole point of HIPAA, which is HIPAA, the Health Insurance Portability and Accountability Act. And HIPAA is all about putting you in control of your own health information. You get to decide what gets shared and what doesn't. Did you have any questions on yours? No? Do you have any others? Okay. So HIPAA is the law that we have to follow. Protected Health Information, or PHI, is the information we have to keep safe. So there's 2 terms there you need to know. HIPAA is the law that tells us what PHI to keep private. Okay? So a good rule of thumb for CNAs is don't give any information about patients to anybody for any reason. If somebody comes in and asks you, like a lot of times family members will come in and they'll say, how's mom doing? What were her labs? What's going on with her? How did she do in therapy? That type of thing. We can't give that information. So we would just say, let me go get the nurse for you. The nurse would be happy to answer those questions. We don't give information at all, ever. And where this really trips up CNAs is that we can't even give information to the patient. So this can get really tricky for CNAs that are taking vital signs. So if you're taking good morning, if you're taking a blood pressure on somebody, okay, they're probably going to ask you, so what was it? Do not answer that question. Because if you say, oh, it was 118 over 82, do you know what their next question is going to be? Is that okay? Is that good? What does that mean? Right? Because you just gave them numbers. Now they need an interpretation of those numbers. CNAs are not allowed to interpret, ever. You can't say, yeah, that's great, that's fine, no problem, because you don't know enough about that patient. Let me give you an example of this. Okay, let's say a patient has a blood pressure. Let's just use 118 over 82, what we just had, right? And they say, is that okay? Now, in your mind, right, we're going to learn normals. 82 is just a tad bit high, just a little bit, I mean, really tiny, tiny bit high. And if you say, yeah, but the bottom number is a little bit high, you've just diagnosed that patient. Just giving them that information is a diagnosis. You are interpreting that result. Now, that patient doesn't understand that little bit of high doesn't really mean a whole lot, and they're going to stress over it. And what do you think that's going to do to their blood pressure, that constant worry? It's going to make it higher. That's right. So what we say can actually impact our patient's health. But let me give you a totally different scenario. Okay. Let's say the patient is on blood pressure medication and they get a blood pressure of 118 over 82 and they ask, how is that? And it is drastically lower than the blood pressure was 2 hours ago. Drastically lower. Same blood pressure, 118 over 82, exactly what we talked about earlier. But an hour ago or 2 hours ago, their blood pressure was 210 over 180. Now it's 118 over 82. And you say, oh, it's much better now. Well, that rapid of a drop can actually have health consequences. It could also mean that something is happening internally with the patient, like they have an internal bleed. Now, you just said, oh, it's much better. And 20 minutes later, the nurse comes running in and puts a head of the bed down and brings a crash cart in with them. And the patient's like, what's going on? And the nurse says, oh, well, your blood pressure dropped suddenly, and I'm very concerned. I just want to be prepared in case we need this. The patient's like, well, but the CNA said it was good. Do you see how that can be very confusing for patients?
Okay, so how do you respond when they ask you, how is your blood pressure? What do we say?
Yep. So great question. Your answer is, I just take it. I give the numbers to the nurse. I'll be happy to have her come in and talk to you about it. I don't know. The machine just gives me the numbers. I don't know. Your job is truly to play dumb. Okay? Don't think. Because, and this does run CNAs into a lot of problems because you want to help. The patient is anxious. They want to know what their blood pressure is. You want to give them that information. And that's perfectly natural and normal to want to share that. And that's not really where the problem is. The problem is that next question. What does that mean? And now we're stepping into territory that we don't belong in. Does that make sense? Be very careful with that. So your best bet is, I just take the numbers. You know, the nurse has to be the one to give you the information. I'm just here to help. Just play it off. You know, and another good response is, that's a great question for the nurse. You know, you can use a little humor in your practice as well. You know, that's a great question for the nurse. Let me go get her. As a nurse, I don't want my CNAs to give any information at all. None. You refer all questions to me because I've been in way too many situations where well-meaning CNAs and you know that truly their heart is in the right place have given information to patients that was wrong for that patient. And then I have to spend twice as long trying to undo that damage and give them the right information and get them to understand what I need them to understand. And it takes so much longer to break something down and then build it back up than if I had just given the information to begin with. Does that make sense? Okay. Patients do not understand your limitations. You are part of a healthcare team. Everything you say, they're going to accept. They're going to believe it because you're part of the healthcare team. And I'll give you a good example of this. And I am a little off topic here, but let me give you a good example of this and why it's so important that we don't provide opinions on anything. Okay. There was a situation that this is years and years ago, probably 30 years ago. I was working with the CNA and a patient got a diagnosis that was very upsetting. Okay. They were very, very upset. And the CNA went in a little while later and the patient was still trying to process. And this, you know, CNAs are trained to encourage patients to talk. You know, so do you want to talk about it? And the patient's like, yeah, I just don't understand. And, you know, was just kind of going on and on. And the CNA, I mean, she had a heart of gold and I understand why she did this. She's like, oh, I'm sure everything's going to be just fine. I'm sure that you'll beat this and everything will be fine. And, you know, keep your spirits up. The patient had just been told that her terminal cancer had spread to multiple organs and hospice was being consulted. And the CNA's like, oh, I'm sure everything's going to be fine. No. So now I've already got a patient that's having a hard time acclimating to this new situation, right? They're terminal. This is a bad thing. They're in denial. They're trying to process. And now they've got this treatment team person who is saying, I'm sure it'll be fine. And that's just going to lead into more difficulty accepting because we just gave them false hope. Does that make sense? So what we want to do is empathize, encourage, let them talk, but don't give them any of you. So the right thing to say there is, oh, that must be very difficult for you. That's it. That's it. That must be very difficult. That allows them to keep talking. Let me go get the nurse for you to talk this through with. That's a great option. But telling them that your aunt had cancer and beat it 5 times, that's not going to help this patient. So we've got to be really, really careful in how we communicate with patients. Does that make sense? Got to be careful here. We want to encourage. We don't want to shy away from patients talking. They've got to talk stuff out. But we want them to do the talking. We're going to open our ears and close our mouths. Good? Make sense? I know it's hard. It's hard. All right. So on Monday, we learned about skill rules. We perform care that's assigned to us on what document? Where do we go to find out what we need to do with each patient? The care plan. Yep. So we perform care as directed on the care plan. And for us, it's the care plan, the whole care plan, and nothing but the care plan. That means we don't add anything to it. We don't take anything away from it. It stands alone. And this is really important on the state exam because your brain will try to put things into the question that don't belong there. Your brain will go, yeah, but if the patient the patient doesn't have that. If they did, it would be in the question. Don't add to it. Don't take away from it. Don't, if it asks you, here's your care plan, ambulate a patient with a gait belt. What equipment do you need to ambulate this patient? The answer is the gait belt. Don't think in your brain, well, if they're weak, we probably need a walker. The question did not say they were weak. Question said gait belt. And this is really where students get tripped up because they expect a trick question. That you kind of expect tests to have trick. There is no trick question. The trick is follow the plan. The easy answer. While we're doing that, we want to observe for any abnormalities, any changes, any pain, anything that we need to report. If you notice it, it's a change. If you notice it, it's a change. So here's a good example. Things that you wouldn't expect, right? When I say you report everything, I mean you report everything. If you notice it, it has to be reported. So if you walked into a patient's room and it smelled like grape Kool-Aid, no, we don't serve grape Kool-Aid. There is no grape Kool-Aid. You look around, there's nothing purple anywhere. That's an observation. As crazy as it is, that's an observation. What do you do with observations? You report it. And the reason is there is a infection, right? A pathogen called Pseudomonas that when it gets into certain body parts, it produces a grape Kool-Aid odor. And it is most common in serious inner ear infections and in some urinary tract infections. So you'll walk into the room, you'll smell grape Kool-Aid. Now, if I didn't tell you to report all observations, you would just go, wonder what time lunch is, right? And you'd go on about your day and your patient would not be receiving the care they need for that infection. So everything you notice, no matter how minor it seems to you, if it stands out to you, it has to be reported to the nurse. Does that make sense? Good. So everything you see, you hear, you smell, or you feel. If the skin feels like sandpaper all of a sudden, and it triggers something, oh wait, that feels strange, different. That's an observation. What do we do with that? Even if it's not red, if the feel of the skin is different, we tell the nurse. Okay. Does that make sense? If you walk in and you're doing, let's say you're doing foot care and the feet are cold, like really cold. That's an observation. What do you do with that? Tell the nurse. That's a circulation issue. So everything that you see or feel or hear or smell has to be reported. That's the most important job you have. Way more important than doing foot care. Way more important than changing the sheets. Way more important than feeding the patient. Whatever you notice, you have to report. And let me explain to you why. As a nurse, this patient is 100% my responsibility. I am liable for everything that's happening with this patient. Legally, I am liable for this patient. Now, in a perfect world, I would only have 1 or 2 patients a day to take care of. And then I would be doing all of the tasks with that patient. I would not need you. I would not have you. CNAs would not exist in a perfect world. Because if I'm going to have the liability of the patient, then I probably need to know everything about that patient, right? Because if they have a wound on their backside and I am doing all of the care on the patient, I'm going to see that wound. I'm going to take care of that wound. If I walk in the room and I smell grape Kool-Aid, I'm going to understand what that means, right? So in a perfect world, good morning, in a perfect world, I would be performing all of this care. And the reason for that is because I would be getting all of the observations and I would make sure the patient gets the care that they need. But we don't live in a perfect world. We live in a world where I have 8, 10, 12 patients. I can't perform all the care on every single patient. I just can't. So I need some helpers. But I still have the liability. So if you are a CNA and you are helping the nurse, it doesn't help if you're not telling them everything you know. Does that make sense? Everything you see, everything you hear, everything you feel, because that's where things get missed. Okay? And you hear this from families all the time. It's very sad, very sad. My mom was in the hospital for 4 days. And right before discharge, before they're ready to send her home, they find a huge bed sore on her backside. Right? Now, she's not going to be able to go home. Now she's going to have to go to a nursing home until they can get that wound healed enough for her to go home because she lives alone. Now, she should have been repositioned often to prevent that bed sore. That was the nurse's job to make sure that was being done. The nurse didn't do their job, or the nurse told the CNAs, make sure you turn the patient, and the CNAs didn't do their job. I don't care who's who. The problem is my mom's got a huge bed sore on her backside, and I don't care how it happened. I care that it happened, right? So as a CNA, we have to make sure that we're following that care plan, that we understand when the nurses are looking over our shoulders and asking us, are you turning the patient? And we have to make sure that we are focusing on the right thing, not what tasks I have to do, but how doing those tasks affects the patient. Does that make sense? Good. It's really important that we have our mind in the right mindset to be a CNA. It's not just enough to show up, put on a badge, and collect a paycheck. And sadly, that's what we have a lot of. It's what we have a lot of. You guys are in demand. I talked to a guy yesterday. His wife is in the local hospital right up the road. We're not going to say the name. But they are so full right now. They have no beds upstairs. Not a single bed for a patient. So people are literally in the hallway. His wife had been on a bed in a hallway downstairs waiting for a bed upstairs. She needed surgery and they could not get to her surgery. It has been, by the time I talked to him yesterday afternoon, it had been over 24 hours that she was in a bed in a hallway waiting on surgery.
Where is that? Here?
Here, yeah. We're not going to say the name of the hospital. Yes, right here. Yeah, our hospitals are full. All of them. All of them. So we need to understand that CNAs are in demand. And a lot of times CNAs are overworked. And your focus is going to be on you. Oh my gosh, I've got so much to do. I've got this task and this task and this and this and this. Don't forget that those patients are somebody's loved ones. And yes, I understand that you are overworked. Absolutely. And they should get you more help. Absolutely. I'm not absolving them of responsibility, but I'm also not absolving you. Remember that under this is a person. And we have to remain compassionate. Do you think that patient, let's just talk about that patient for a second. She needs surgery. She is in excruciating pain. She's not even in a room. There's not even a curtain around her. She can't get out of bed, which means she has to use a bedpan in bed in a hallway. How comfortable do you think she is?
Not very comfortable.
Not very comfortable. There's no privacy. So what do you think her mood is going to be like?
Pissed off.
Oh, yeah, because she's still paying to be there.
Yeah.
That's not free. She doesn't have a room. She doesn't have dedicated staff. And yet she's still going to get a bill. And that bill is going to be substantial. So do you think her mood, do you think she's going to be all sunshine and rainbows
I don't know.
when you walk it, you know, when you talk to her? No. So we're going to take offense at that. We're going to get a little attitude because, you know, I'm overworked and you're going to treat me like that. We kind of get it confused. Does that make sense? Okay. Understand that your patients have the right to be a little off, especially if they're not getting the care they're paying for. Okay, good? Makes sense? Anybody here a server? Anybody ever a server? I don't have any servers. Yes, servers make great CNAs because they understand this concept. Okay. If you are a server at a restaurant and your food is delayed, it comes out cold, it's, you know, everything goes wrong, nobody's filling up your cup, right? And you have to pay for that meal at the end. You know, you have to pay.
No tip.
So yeah, you're probably not gonna tip, sure. And we're automatically gonna blame the server. We're automatically, because that's the face. That's the person wearing, it's probably the cooks in the back, but that's not who we're blaming. We're blaming the server because that's the face that we interact with, right? You guys are all the face that you're interacting with. Now you're probably going to contact the manager, right? You're going to call the manager over. Hey, my food was late coming out. It was cold. I didn't get, you know, refills. And the manager's probably going to say something like, I'm so sorry. We had this huge rush. I don't have enough servers on staff. We're short a cook. We're trying to, you know, keep everything. Does that matter? No, you want a discount on that bill, right? You paid for a service. You didn't get the service you expected. You want a discount on that bill. And you're probably going to raise a ruckus until you get that discount, right? Well, it doesn't work like that in healthcare. There is no manager, right? You can ask for a manager all day long. Nobody's coming to your bedside. You're going to get that $30,000 bill in the mail, and you can call up billing, and they don't care. They're going to send you to collections. They don't care. So who is the one person you're going to blame for all of this? The one that you saw, the one in front of you. So understand that your patients are probably going to take out their frustrations on you just because you're the one that's there. Smile through it. It's okay. Do the best that you can, but don't retaliate to them. It's not their fault that they're stuck in a hallway. Does that make sense? Yeah. It's interesting because that particular guy that I talked to yesterday, he was complaining to me that his wife is stuck in a hallway and she, doesn't even have privacy to use a bedpan. He's going on and on. He's not even the one that's stuck in the hallway, right? But he's upset for her, and I get it 100%. I'm a nurse. He knows I'm a nurse, so of course I'm going to be the face that he's going to complain to, like I have any pull that I have no way of influencing this, but I'm going to listen. I'm going to make the right sounds. I'm going to say, I'm so sorry. That's awful. I wish there was something I could do about that. That's awful. But I would definitely complain, and try to get her moved to a room. But if you're the only person that they have access to, you're the one that's going to bear the brunt of it. Now, I had no impact on that. I had nothing to do with that, but I can still respond graciously. So remember, that's your job. To be a good conversationalist, close your mouth, open your ears. That's what it takes. Let them talk it out. Okay? All right. We also learned how to start every skill. Every skill starts with the opening. Every opening starts with a knock. We always knock before we enter the patient's space. Once we enter, we greet the patient by name. Be nice. Hello, good morning, good afternoon. Be nice. And then you're going to address that resident by name. Remember that you can't touch a patient until you've washed your hands. So don't reach over to uncover their hand to look for a ID band during the test, because you have touched that patient before you wash your hands if you do that. Okay, be careful with that. I actually just talked to a instructor earlier this week who was having trouble. She's in Texas. She was having trouble with her students. She's like, I don't understand this. The evaluators are failing my students, and I don't understand why. And I said, well, walk me through your process. You know, how are you teaching them? What is your process? And she says, well, they go into the room and they check the ID band before they ever start. And I said, well, there's your problem right there. Stop. I said, you are having your students touch the resident before their hands are clean. She said, yeah, but they just wash their hands at the end of, the last skill. I said, that does not matter. Think of all the things that they've touched in between. Doorknobs, equipment, supply rooms. You can't touch that patient until your hands are clean in their room. So walking in and touching that, looking for that ID band, you are violating this. It is a checkpoint. These aren't arbitrary. These are not nice to haves. These are things we have to do. Okay? Don't call your patients honey, baby, sweetie. Let's keep this professional. Let me talk to you about that real quick. This is a hot button of mine. All right. Sorry, guys, I got a headache. All right, so let me explain this. I think our society has become a little too informal. I don't think that everybody needs to be on a first name basis, especially when it comes to professional interactions, because you lose that professional separation. I do not call patients by their first name. If I walk into a patient's room and I say, hi, Mr. Smith, how are you? And he says, oh, call me Harry. I'm not calling him Harry. I'm calling him Mr. Harry. I want that professional separation. I'm going to be doing things with this guy that we don't need to be on a first name basis for. And I want to remind him that this is a professional interaction, not a personal one. So I think that in a lot of professional settings, we have lost an advantage by using first names on everything. So I'm a Southern girl, so I put Mr. or Miss in front of first names. I do that with pretty much everybody that's older than me. Very rarely will I call an older person by their name. It's always Mr. or Miss, unless they're like part of my family, right? Unless I have a personal relationship with them. But if it's a neighbor, yeah, that's Mr. Cliff. And I do that because there needs to be a separation between personal and not personal. I would advise you to think about these things when you go into healthcare. How do you want to structure your practice? Okay. There's nothing wrong with using first names if that's the way you want to go. Legally, there's nothing wrong with it. But I do think that there is a disadvantage to you. So I usually try to stick with last names. Hi, Mr. Smith. Okay. All right. Once we have the introductions out of the way, we want to tell them, oh, yeah, I'm sorry. You have to tell them who and what you are. I forgot about that. Once we get the introductions out of the way, you have to tell them why you're there. I'm here to whatever. So you can read it right off the care plan. You can put it in your own words. Doesn't matter. But I'm here to do foot care. I'm here to do range of motion. Here to get your vital signs. Here to turn you on your side. Here to take you for a walk. Here to put you in the wheelchair. However you want to put it is fine. But they have to know what you're there to do, because you have to get consent. Is that okay? Can I do that? Can I help you with that? And that's usually how I try to frame this. I'm here to help you with, because I'm not there to take over anything. This is a human adult. They have bodily autonomy. They just need my help. And when you keep that mindset, it helps with your interactions. If your mindset is, I'm here to do all of this to you, you have dehumanized that person. I'm here to help you with getting out of bed. I'm here to help you with some range of motion exercises. It helps restore the autonomy of the patient. It gives them that independence that they need, that autonomy. When you make a patient too dependent on you, they'll use that call light all the time, because you've made them dependent. You want to restore that autonomy. So the way that you approach this actually matters, okay? So get consent, and then you're going to close the privacy curtain. That curtain is not clean. So once we've closed the curtain, we're going to go wash our hands. After we've washed our hands, then we can get our supplies. Our cardinal rule here, the one thing that we cannot violate no matter what, is do not touch that patient until your hands are clean. This is the one checkpoint that will absolutely fail you. And it's because of the consequence to the patient, not because you forgot a step. Okay. Good. Does that make sense? All right. We also learn how to end every skill. Well, let me go back one. Hold on. So with the opening, it sounds like this. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? I'm here to whatever. Is that okay? Let me go close your curtain, wash my hands, get my supplies. I'll be right back. I always tell the patient I'll be right back, because if I say I'm going to perform foot care, is that okay? And then I turn around to leave, my patient's now stuck. What am I supposed to do? Am I supposed to go with you? Am I supposed to get out of bed? What is my role here? What do I do? So I always tell the patient exactly what I'm doing. I'm going to close your curtain, wash my hands, and get my supplies. I'll be right back. Now my patient knows there's nothing they need to do. They can just chill. They're good. But if you don't do that, you'll find your patients trying to get out of bed to follow you places, because they don't know what is expected of them. Remember that this is the one thing I try to remind students. You guys all decided to take a class to become a CNA. Why? Why are you here? Why did you? Because you can just challenge the test in Florida. Why did you decide you needed a class? Why? Okay, you wanted to learn how. You wanted to learn the steps. You want to do it the right way. That's why you're here. Okay? You want to learn. That means that before Monday, you did not know how to do these things. Is that correct? I want you to remember that every day that you were a CNA, that there was a time before you took a class that you did not know how to do these steps. Because when you go in and you start working with patients, you will automatically start attributing that knowledge to them. You will assume that your patient knows what you're doing. You had to take a class to know what you're doing. Don't assume your patient knows what you're doing. Remember, there was a time that you did not have this knowledge, and that's where your patient is at. The biggest mistake that I see CNAs make out there is to treat the patient like they should know what's coming next, what you're doing. They don't know. Why would they? They're not CNAs. They didn't take the class. So it's up to you to tell them every step of the way what you're doing. So there's a question I get asked a lot. Do I have to say everything you say when I'm doing the skills? And the answer is you should. But you'll get 2-3 years into being a CNA, and you'll forget this conversation, and you'll start treating these patients like they should know what's coming next. Don't do that. Don't do that. They don't know. Great example of this. I went last night up to Citrus County and met my daughter and my mom. So 3 generations. We went and had a pedicure. I get a pedicure about once every 6 or 7 years. I never get pedicures, ever. I can't even remember the last time I had one. So I don't know the process. Like, I don't know when to put my feet in the water and when to take them out. I don't know. I don't have this done. I'm not familiar with the steps. So the girl that was doing my pedicure was getting irritated at me because I didn't know when to put my feet in the water and when to take them out and when to, put them up like this and when to put, I didn't know. And she's like getting irritated with me. Yet she does this all day. I don't. Don't make that mistake with your patients. Because now I'm feeling bad that I don't know when to put my feet in the water. I mean, is that the position I should be in as a customer? Yeah. I still tipped her, and I still tipped her well because it's a service industry, and that's what I do. But she probably could have used just a little more training on that. Good? Makes sense? But I do have pretty pink toenails today, so.
I want to ask you a question about the during the test. You can on the opening, you knock the door, and you're gonna be getting grade for the opening that you're saying. Like, good morning, Miss Patty. My name is Sylvia, and I'm here. I'm your CNA today. I'm here to wash your teeth, brush your teeth,
Right?
and I'm going da 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 da. We have to say everything during the opening.
Yes.
And they are going to be evaluating that, or
Right. So let me go back a couple slides and show you, okay? Do you see down here?
yeah.
Do you see this? This right here? This is the actual checklist. So we're getting a check mark to knock,
Okay, yeah. So nothing okay. Bye.
right? We're getting a check mark to greet the resident, address them by name, and introduce ourselves. So, good morning, Mr. Jones. My name is Patty. I'm your CNA today. And then, right, we have to greet the resident by name. We get 2 more check marks for this. So if we walk in and we just say, "Hi, sweetie, my name is Patty," we don't get the check mark. Okay, so remember that we have multiple check marks for that. Okay, then we have to tell them who we are. My name is Patty, and I'm your CNA today. Then we have a check mark that says provide explanations, right? Provide explanations to resident about care before beginning. I'm here too. Then we have to ask them about preferences, which means, is that okay? Good? Make sense? Okay. Now, we do have to close the curtain, and we don't have to tell them we're closing the curtain. So if you miss verbalizing that, it's okay. I like to tell my patients what I'm doing. We do have to wash our hands. Okay. Refrain from touching resident before hands are clean. So we have to wash our hands.
We don't have to say during the test. If I forget to say that,
If you forget to say, I'm closing the curtain. If you forget to say, I'm going to go wash my hands. If you forget to say, I'm getting your supplies, that's fine. You just have to do it. I want you to try to remember to say it, because if not, well, I'm going to use you as an example real quick.
I know. I saw your videos.
Yep.
I saw your videos, and you always say that.
Always. Yes. So if I come up to you, and I'm just going to use you as a patient real quick. So, hi, Sylvia. How are you today? My name is Patty. I'm your CNA today, and we're going to go for a little walk. Is that okay?
That's kind of creepy.
Did you want to go for a walk? That whole time you're sitting there thinking, well, wait, if I'm going to go for a walk, am I supposed to go? What am I? This is weird. This is creepy. This is just strange, right? What's going on here? What is expected of me? That's what's going through your brain right now. And you guys are all thinking that that's theater, right? That would never happen. That happens all the time. Happens all the time in healthcare. The CNAs will just go in, they'll talk to the patient, and then they just wander off. And the patients are like, "What? This is creepy. I'm sitting here. What's happening?" Right? So, yes, you should say all of those things, because let's rewind. Good morning, Sylvia. How are you today? I'm Patty, your CNA today, and I'd like to help you go for a walk. Is that okay? All right, let me just close the curtain, wash my hands, get my supplies, and I'll be right with you. Big difference. Big difference. Does that make sense? Okay. So, yes, you can forget to say you're closing the curtain, washing your hands, and getting your supplies, but that leaves your patient kind of sitting there. Now, if you remember, I told you that every checkpoint is about the patient. So the evaluators are sitting there, listening to all of this, seeing the effect of that on the patient, and that's what they're grading on. Make sense? Good. All right, so we're going to end every skill the same way with the closing. Now, the closing is much longer. Closing is much longer. So it doesn't matter what order you do the closing in, except for the last two. Last two do matter, but the rest of it, however you want to do it, is fine. We want to make sure your patient's in a clean and safe environment. So I'm going to look to see, is the bed in the lowest position? Is my environment clean? I always leave my patient looking better than I found them. That's a great principle to live by. So you'll see me, when I'm doing the closing, you'll see me straighten out the sheets. Right. I'll give the patient the call light. Here's your call light. Make sure everything looks good. Clean up the table. All right. Everything looks good. Right. So I'm going to make sure they're in a clean, safe environment. Now, clean is important because you don't rest as well in a cluttered environment. You just don't. If you have high anxiety, the very first thing that I recommend is you declutter. Declutter. Get rid of everything. In fact, the closer you can get to bare, the more effect it'll have on your anxiety. So if you suffer from anxiety, get yourself a room that has nothing in it. Put a chair in there, a comfortable chair. And when you start getting anxious, go in there. Seclude yourself. Because clutter contributes to anxiety. Do you think your patient has anything at all to be anxious about? Right? They are a bundle of anxious. So if we have a lot of clutter around them, especially in a healthcare setting where a lot of the clutter is stuff that looks like it might hurt. Think about all the stuff we use in healthcare, right? So I want this environment as calm as I can get it. If the patient has some flowers like over there, I might bring the flowers a little closer. And, I want this to be a safe space for my patients. So clean and make sure the bed is in the low position. We're going to ask them if they're comfortable, and the test needs to hear this word. This is our checkpoint. Ask resident about comfort. They need to hear that word, comfort. Are you comfortable? Do you want the head of the bed adjusted? Do you want your TV remote? We're also going to address preferences. This is a graded checkpoint. So I'm going to offer a magazine. The magazine's the easiest way to do it for the test. Just offer a magazine. And we're going to make sure they're covered. Now, if they have clothes on, you don't need a sheet. But if they don't have clothes on, we need to make sure they're covered. I should not see their knobby knees. This patient is undressed, laying down. That is a vulnerable position. Now, do not think that just because somebody is in a healthcare setting that they're safe. They are not safe. They are not safe. They don't know their roommate. How do you know? How do you know that that roommate is not a sexual predator? How do you know? We don't do background checks on people when they come in. You are placed in a room with a complete stranger. You are undressed and you are laying down. How do you know that that person is safe? How do you know that a visitor that wanders in and out is safe? Do we do background checks on visitors? Now, here's the really scary part. Background checks don't keep you safe either, because healthcare workers assault patients. We just had one about 6 or 7 years ago. A female patient who had been a drowning victim. She wasn't cognitively aware. Okay. So she's in a persistent vegetative state. She ends up pregnant and gave birth as a CNA is washing her. Nobody knew she was pregnant. She was nonverbal. She was non-communicative. Nobody knew she was pregnant. She's on a tube feeding, so controlled calories. She didn't gain any baby weight. CNA is in there washing her, giving her a bed bath, turns the patient over on her side. The patient moans, and a baby slides out.
Oh, that's scary.
Oh, yeah. You should hear the 911 call on it.
Premature baby.
So, well, it actually was full term.
It was?
Mm-hmm.
That's surprising.
So your next question is, hold up. She is nonverbal. She is, for all intents and purposes, brain dead. She cannot give consent. So this is automatically a sexual assault case. She cannot give consent. Somebody raped this patient. Who? Who raped this patient? Who do you guys think?
One of the nurses.
That's right. It was a nurse.
Is he in jail?
Absolutely.
Thank God.
They did a DNA test. Came back. Absolutely. Do not assume that your healthcare providers are upstanding citizens. Just because they passed a background check, that just means they weren't caught. One of the worst pedophiles in our country was a pediatrician.
Wait, who was it?
I don't remember his name. Yeah. Yeah. Don't assume that just because somebody has a medical license that they're not a bad person. And this hit much closer to home. Up in Citrus County, right next county up, we had a nurse who worked in the recovery room after surgery back in the 90s who raped and sexually assaulted multiple women while they were under anesthesia. Was convicted, went to jail, is still in jail.
You should go to prison for that.
Yeah, well, yeah.
Public humiliation.
Yeah.
Wait,
Don't
how-
assume.
How they find the baby's father? Did they do a DNA?
They
test
did a
on
DNA
all-
test, yes.
on all like.
Yes. All male caregivers in the
Yeah.
facility, yes.
Hmm.
Yeah. So do you think this patient is safe?
No.
They are not dressed. They're in a gown. They are not dressed. They are laying down, which is vulnerable. They have to sleep at some point. They're in a room with a total stranger who has not been screened. They are surrounded by other strangers who have been screened, but that means nothing. Do you think this person is safe? So we need to make sure that they're covered, because this isn't completely safe, but it's a whole lot more safe than that. Do you guys understand the difference? Okay. If I leave the patient like this for too long, you guys are going to get uncomfortable.
Yeah. Can you put the sheets back on?
So we have to make sure they're covered. Are you guys starting to understand that this test is about the patient? Do you guys get that? It's about the patient, not about, did I forget a step? I've been doing this CNA training for over 20 years now, and we've had students that went on. I actually have a student that got her doctorate in nursing. We've got multiple nurse practitioners that started out in my class. We have lots and lots of RNs. Oh, yeah. Alicia says, I remember taking your PM class over 10 years ago. Welcome back, Alicia. Yeah, so we have students. Oh, thank you, Marie. Thank you. We have students that are going to be your supervisors. Okay. I've been doing this for a very, very, very long time. And I actually ran into one of my previous students right up the road at a big box store. I'm not going to say the name of. And she comes up, she goes, oh my gosh, Miss Patty. She says, I see your live streams all the time, and I think that's really awesome. She says, but let me tell you, the biggest thing that stuck with me, when I walk by a room, if I look in the room and I see a patient without their sheets on, I have to go in and pull their sheet up. She's like, I can't stand that. Because you're thinking like a patient. And that's awesome. So 8-10 years later, they still have that lesson. So don't forget that one. All right. We're going to open the privacy curtain. No need for privacy at the end of the scale. This I get questions on a lot. Do I have to open the curtain? And the answer is no. If the patient doesn't want the curtain open, that's fine. Leave the curtain closed. Not a problem. But that is an observation. What do we do with observations? Tell the nurse. If it's not business as usual, the nurse needs to know. Now, why would the nurse need to know that the patient doesn't want the curtain open? Why would that be an issue? Well, there's a couple of different reasons. Number one, the patient might be doing something that they don't want the staff to see. That's something I probably need to know, especially if it's drugs. Because if I'm giving that patient a narcotic for pain and they're doing outside drugs, that could put the patient into respiratory arrest, right? That's a concern. So if they've got that curtain closed, maybe they're doing something that I need to know about. The second reason is maybe they are depressed and isolating. That's a possibility too. I need to keep my eyes open for that. Maybe I need a psych consult for this patient. If they're wanting the curtain closed all the time, maybe it's because they're trying to sleep because they didn't get any sleep last night because the staff was too busy in the hallway yapping and making noise and kept everybody up. That's something I need to know too. Right? So there's a lot of reasons that patient might want that curtain closed, and all of them are something I need to address. Now, if I don't know about it, I've got a lot of opportunities there that I've missed. Does that make sense? So if it's not business as usual, who needs to know? The nurse. Good? All right, and we're going to give them their call light. Doesn't matter what order you do those things. You can give them the call light after you open the curtain. That's fine because curtain's sturdy, call light's sturdy. It's fine.
Oh, no.
Okay. Okay. All right. So once we've done all of those things, we're going to go wash the patient's cooties off of our hands. Go to the sink, wash your hands. Now, once you've washed those patient's cooties off of your hands, if you come back over to the patient and you hand them the call light, or you realize you didn't open the curtain and you open that curtain, if you do any of those things, you've re-cootied up. You would have to wash again. So make sure you get all of those things done. I don't care what order you do them in. Make sure you get all of those things done and go wash your hands. Once you've washed your hands, you're done with that patient. Done with that patient. If you have to go back to the patient for any reason, you got to wash again. Think of cooties. Okay, good. All right. If you have to document, if it's a documentation skill, then you would document and then wash your hands again. And the reason is, oops, let me get to this one. The reason is this checkpoint. Do you remember at the very beginning during our opening, I told you that if you don't wash your hands before you touch patient, it's a fail? That's this as well. If we don't wash our hands after patient care, it's an automatic failure. And that's really, really important because it's all about infection control. Okay, does that make sense? So one of the illustrations I like to give for this is, anybody here like to ride roller coasters? Anybody ride a roller coaster? Okay. So imagine for a second you go to a theme park and you get in line to ride the roller coaster and you get up to the coaster and you get seated and they bring the bar down and they say, okay, just so that you know, there's 25 seats on this roller coaster. One of you guys is going to fall out. All right, bye. Have a great trip.
Oh,
One of you guys is not making it. You guys want on that ride?
no.
Those aren't very good odds, are they? 1 out of every 25? Okay. In a hospital, in a healthcare setting, 1 out of every 25 patients gets an infection they did not come in with. Same odds. And it has just as much chance of killing that patient as that roller coaster. This is why. This is why. Because we, staff members, are bringing the patient pathogens that they did not come in with. That's why this is an automatic fail. Do you guys understand how important that is? I don't ride roller coasters. Okay, so we have to end our skill with a patient that feels cared for and cared about. Okay, we learned how to wash our hands and we kind of had to rush through this a little bit, but we're going to wet our hands before we apply soap. We're going to wash all surfaces, the wrists, the back of the hands, in between the thumb and index finger, the palm of the hand, interlacing those fingers, and the bottom of the hand by the pinky. So we are going to wash all of these areas for at least 20 seconds. Minimum. Do not use songs to time this because when you're testing, you're nervous. And when you're nervous, your singing speed speeds up. Don't use the song. Use the clock. There's a clock right there above the sink. Use it. That's what they're using. And then you're going to move on to your nails. So you're going to clean the nails by taking your thumb down each nail. Circle the nails on your palm to clean underneath. And then you're going to rinse. And when you rinse, you want to keep your hands in the sink area. You're going to tap to keep the water in the sink. That water is still running while we dry. Once we dry, then we're going to throw those paper towels away and use a clean, dry paper towel to turn that water off. The water temperature for washing your hands does not matter. Nobody cares what temperature that water is. Now, water temperature is going to play a factor in bathing patients later, but not when you're washing your own hands. I don't care what temperature that, nobody cares. That water would have to be boiling to kill germs. You're not going to wash your hands with boiling water. Okay. So water temperature is all about your comfort, does not matter. Good? Makes sense? Okay. Don't sing. So remember that we have to wash our hands before and after every single skill that we do. Page 46 is going to tell you about this, but I'm going to break this down really quickly. During the exam, remember that there's 8 people testing. So 1, 2, 3, 4, 5, 6, 7, and we'll make that guy 8. Okay, so we've got 8 people testing. You are each going to do 3 skills. You have to wash your hands before and after every skill. So that means 6 hand washings, 6 hand washings, 6 hand washings. And that's actually not even accurate because on documentation skills, remember everybody gets a documentation skill. You have to wash your hands before you document and after you document. So documentation skills are 3 hand washings. So that means that you're going to wash your hands before and after skill 1, before and after skill 2, before and after skill 3, and then after documentation for skill 3. Okay. So that is 7 hand washings. So 7 for you, 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 and 7 for them. Okay. Good. Makes sense. Those evaluators want to be home. That's where they want to be. They want to be in their pool, drinking their margarita. They do not want to be watching you wash your hands 7 times and 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 you wash your hand. I mean, oh my gosh, can you imagine how boring that job would be? So the evaluators are going to tell you after your first skill is done. So you washed your hands, you did your skill, you washed your hands. They've seen 2 hand washings, maybe 3 if it was a documentation skill. They're going to tell you at that point, you can simulate hand washing from here on out. So you're not going to physically wash your hand for at the beginning of skill 2 and the end of skill 2, the beginning of skill 3 and the end of skill 3. Does that make sense? Simulate just means say. You're going to tell them when you would wash your hands. So I would do this. Good morning, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Awesome. I'm going to close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I would wash my hands now. I'm going to go get my supplies. Okay. This is a way of shortening the skill for you. So, you can meet that time requirement. Remember on page 25, we had the little clocks on the clipboards, right? So it helps shorten the skill for you, but they've seen you wash your hands. So don't simulate until they tell you to. But at some point, they're going to say, hey, you can simulate hand washing from now on. You would just say, I would wash my hands here. You don't have to go to the sink. You don't have to mime it. You would just say. Simulate means say. Good? Good. Let's talk hand sanitizer. One of my favorite topics. This is Jeremy. Isn't Jeremy cute? All right. So hand sanitizer is an option used in a lot of healthcare facilities. There's nothing wrong with it. In a lot of cases, it's preferred. But the problem with hand sanitizer is we don't use it properly most of the time. In order to use hand sanitizer and have it be effective, we don't just use a little bit. Like this is what we normally do, right? And we just kind of rub it together and we're done. That does not kill the pathogens. We have to get enough hand sanitizer to keep our hands wet for at least 20 seconds. Where did we hear that from before? Washing our hands. So we have to get enough. I mean, you see how wet my hands are? We have to get enough hand sanitizer to keep our hands wet for at least 20 seconds. And we have to cover all of those same areas. So the backs of the wrists, in between the fingers, the palm of the hand, in between the thumb and index finger, and the bottom of our hand by our pinky. So we have to do the same actions for the same amount of time as hand washing. And yet we don't normally do that with hand sanitizer. We just get a little squirt, we rub it together, and we go on our way. Well, think about all the pathogens that are on all the areas that you missed, right? But there's another problem with hand sanitizer that most people don't really think about. When I use hand sanitizer, well, when I wash my hands, where do the pathogens go? When I go to the sink and I wet my hands and I use some soap, where do they go? Down the drain. Yeah, absolutely. If I use hand sanitizer and I rub my hands together, where did the pathogens go? Yeah, they don't pop into the atmosphere. It doesn't work like that. They are still on my hands. They might be dead, but they're still there. So if I pick up a sandwich and eat that sandwich after using hand sanitizer, I am eating that sandwich with a side of dead E. coli, which isn't much more appetizing than live E. coli, really. So if you're going to put your hands anywhere up here, anywhere, you probably ought to go wash them so the pathogens are down the drain, not hanging out on your hands. Make sense? Good? Okay. All right. Now, the real problem with hand sanitizer is that it doesn't kill our two heavy hitters. So C. diff and norovirus are two pathogens that are not killed by hand sanitizer. Norovirus is called the daycare disease or the cruise ship disease, and usually once or twice a year, you'll hear about a cruise ship that has to be cleaned from head to toe because, you know, they had an outbreak of norovirus. It spreads very rapidly in confined spaces. Well, you've just described a healthcare setting. So if we get norovirus in a healthcare setting, it's going to spread like wildfire. And it is not killed by hand sanitizer. Now, norovirus will make you feel like death warmed over for 3 days. Stuff comes out of both ends for 3 days, and you feel like you're going to die. It's awful. It's absolutely awful. But if you think that's bad, let me introduce you to its older brother, C. diff. Because C. diff will make you sick for 6 to 8 weeks. Like you can't hold anything in. You will drop weight. And if you already have something else working on you, if you're trying to recover from a surgery or an illness or something like that, and you get C. diff and it depletes your system, it can and probably will kill you. And hand sanitizer does not prevent spread of C. diff. So we've got to be really careful with our hand sanitizer use. If your patient has vomiting, nausea, or diarrhea, you should not be, if you just walked into that room, you should not be using hand sanitizer. You need to be using hand washing. Make sense? Good? All right. So if we're going to do anything that has to do with our face, like talking on the phone, eating or drinking or smoking, we want to make sure that we are washing our hands, not hand sanitizer. Saw a meme the other day. I thought it was really, really cute. It says, healthcare, the only industry where you have to wash your hands before you go to the bathroom. And that's true. It's true. You need to wash your hands before you go to the bathroom and then again after. All right, so we have mastered these 3 principles. I told you on the back wall we have 11 that we're going to learn. We've got 3 down. It wasn't too bad, was it? All right, we're going to learn a few more today. Actually, 3 more today. These principles are not on the care plan. You have to know they have to be done. All right, so we got 3 out of the way. We have skill rules, the opening and the closing, but we need to learn glove rules, and that's where we're going to start today. So if you go to page 40, we're going to talk about glove rules. So if you look at this page, this is our overview page. You can see the banner that we're about to learn. You can see that it applies to every single skill. I have a video on it that you can watch on your own if you'd like. And the notes for what I'm about to say are on page 41. Gloves are the most misunderstood component of healthcare. And I'm about to change your mind on a few things. Okay. I need you to stay with me as we go through this lecture. In order to understand why gloves are misunderstood, we're going to talk about gloves from a different industry as an example. And I'm going to talk to you about food service, right? How many of you guys have ever gone to a place that built a sandwich in front of you? Have you ever gone to a sandwich shop where you told them what you wanted and they made the sandwich in front of you? Okay, so that's what we're going to do here. We're going to build a sandwich together. Now, I'm going to build the sandwich. You're going to tell me what you want on it. Do you want me to put gloves on?
Yeah.
Why?
I don't want my food contaminated.
All right, you don't want me to touch your food, right? You don't want your food contaminated. So you feel safer if I'm wearing gloves. Everybody agree with that? Okay, I'm going to put on a pair of gloves. And then we're going to get started. So first, we need some bread. What kind of bread do you want? White, wheat? White. So I'm going to go to the bread cart. I'm going to open up the little thing that's hanging down. I'm going to grab a thing of white bread and close it. And I'm going to put that white bread on the counter. I'm going to pick up the knife that's laying there, and I'm going to slice that bread in half and fold it open to make sure that I can get everything on it. All right, good job. How about some mayo? Well, we're going to get to more in a minute, but let's get some mayo. So I'm going to reach into the little mayo thing, and it's always got that spatula sticking out. So I'm going to grab that spatula. I'm going to pick it up, and I'm going to, put the mayo on the bread and put the spatula back. So how about some other sauces? Do you want spicy mustard, honey mustard, chipotle? Chipotle. So I'm going to grab the chipotle container. I'm going to tap it, right, to get everything pushed down, and I'm going to squirt it on there, and I'll put the chipotle container back. Let's put some bacon on here because everything is better with bacon. So I'm going to get the bacon out of the little fridge at the bottom and open the wrapper and put some bacon on the sandwich. And what kind of meat do you want? Ham. All right. So I'm going to get into the cooler underneath the counter. I'm going to open the cooler, get the ham out, close the cooler, and I'm going to put the ham on the sandwich. This sounds like a pretty good sandwich so far. What kind of cheese do you want? American. So I'm going to go to the cheese drawer, but I'm out of American. Hold on one second. I'm going to have to go to the big freezer, the walk-in cooler, and I'm going to get the hunk of American, and I'm going to go to the slicer and slice off some American. So you got some fresh cheese on your sandwich. So we're going to slice that up and put it on the sandwich. Do we want this toasted? Yeah. So I'm going to put the sandwich in the toaster, but right now it's actually a little bit busy, so we got to wait just a minute. Once it's available, I'll slide it in. I'm going to press the buttons to put the timer on. We'll wait. Once it's ready, we're going to grab that paddle and because it's hot, get the sandwich out. And now we're ready for toppings. Do you want lettuce? So I'm going to reach my hand in, grab some lettuce and spread it out on the sandwich. How about some tomatoes, or you want tomatoes? All right, so I'll get some tomatoes. Pickles or olives or jalapenos. All right, you like spicy stuff. So I'm going to get some jalapenos and put them on. Any other toppings that you want? What's that? Pickles, yeah. We're going to get those pickles and squeeze them out, right? So it doesn't make our sandwich all soggy. We'll put those pickles on. And now I'm going to take that knife and put it into the sandwich so I can fold it, because our sandwich is pretty big, and pull that knife out. And then I'm going to wrap it up in the wrapper and put it in a bag. And I'm going to hand it to you. And now you're ready to eat your sandwich. Good sandwich. Oh, that sounds like an awesome sandwich. You guys want to eat your sandwich?
Nope.
Why?
You haven't changed your gloves.
Okay, but you guys wanted me to wear gloves before I started. You thought those gloves were going to keep your sandwich clean.
Oh, you're supposed to change them?
Yes.
Well, let's think about all the things those gloves touched as I was making the sandwich. So it touched the bread cart, it touched the knife, it touched the mayonnaise spreader, it touched the sauce bottles, it touched the bacon package, it touched the cheese drawer, the cooler containers, the slicer, the counter while we were waiting, the controls on the toaster oven itself, the paddle, the toppings, and the sandwich. Did those gloves do what you thought they were going to do? No. But less than 5 minutes ago, you wanted me to wear gloves. You told me.
Use your bare hand.
Yeah. So we have to think now about who those gloves were really there to protect, right? So if we're trying to figure out were these gloves effective, it depends. If those gloves were there to protect the worker from touching your sandwich, were they effective? Yes. But is that really what we wanted them to wear gloves for? We wanted them to wear gloves to keep our food clean. So did those gloves do what they were supposed to do? No. So you had a false sense of security. Do you guys understand that? You had a false sense of security. And this is a problem because this relates to healthcare in a very big way. Because in healthcare, we wear gloves, but we wear gloves without being really aware of why we're wearing them. And because we're not aware of why we're wearing them, we're putting people at risk. And we see this all the time in healthcare. Patients will walk in the room, they'll put on staff members will walk in a patient's room, they'll put on a set of gloves, and then they'll pick up some Kleenexes off the floor and throw them away, and they'll close the privacy curtain, and they'll empty the urinary drainage bag, and then they'll pour the patient a cup of water and hand it to them. What did we do?
You didn't change the gloves.
Yeah, we contaminated something the patient is going to be accessing. That's a problem. And we do it in healthcare without even thinking about it because we're not aware of what we're touching with gloves. And that's the problem. When you wear gloves without thinking, you quit thinking about the gloves. Good? Make sense? Okay. In order to understand why this is important, we have to talk about something called the chain of infection. And I have a whole lesson on this on page 123. So in the middle of page 123, you see this graphic. Here it is bigger on the screen. And CNAs need to have a little bit of an understanding of the chain of infection. So every infection starts with a pathogen. No pathogen, no problem, right? If I don't have hepatitis B, I can't give it to you. You got to have a pathogen. That pathogen needs a place to live. That place is called a host or a reservoir. Host if it's living, reservoir if it's not, but it has to have a place to live. Pathogens don't do well out in the open. Most pathogens will die out in the open, usually within a very short time period. So if I have, let's say, some body fluids on this table, once those body fluids dry, the pathogen is dead. Pathogens have to live in moisture. So once that dries, there's no pathogens. So pathogens don't live outside of the body for very long. It's important that you understand that. But they have a place that they call home. And that place is very comfortable for them. Pathogens like their home. They're not trying to get out. They got cable TV, they got comfy couches, they've got snacks and microwave. I mean, they got everything they need to be comfy. They're sticking where they are. They're happy. Thank you very much. Okay. Now, that pathogen is not trying to get out. Not even on its radar. In order for that pathogen to leave its host, it has to be forced out. Now, pathogens cannot drill through the skin. They don't come with little mini jackhammers. It doesn't work like that. They cannot drill through the skin. Pathogens have to leave through a doorway that's already in the body. So a doorway is anything that lets fluid in or out of your body. So eyes lets fluid in or out of the body. The nose lets fluid in or out of the body. The mouth, fluid in or out of the body. The genitals, the rectal area, wounds, rashes, sores, and incisions. These are all places, doorways, where fluids can get in or out of the body. Okay, if we have a doorway, it means a pathogen in fluid can also get in or out of the body. Make sense? No jackhammers. They can't drill through skin. I can put HIV positive blood on my skin and it cannot penetrate into my body. Everybody got that? Okay, it has to go in through a doorway. Question? No? Okay. So if I put you guys on break, which I'm going to do in a few minutes, and you decide to go outside, how are you getting outside of this room? You're not going to knock a hole through the wall? No, you're going to use a doorway that's already there for that purpose. That's what these are. They're not going to knock a hole through a wall. They don't have the equipment to do that. So remember that pathogens cannot spread through the skin. So I can touch skin with my skin and it's not a risk. Skin to skin contact is not a risk. So those of you who think I'm going to wear gloves for everything in a healthcare setting, I'm not ever going to touch a patient's skin, you are now wearing gloves without thinking about it. And when you wear gloves without thinking about it, you stop thinking about your gloves and you put your patient at risk. Does that make sense? You do not need gloves unless you're going to be working around a doorway. Does that make sense? Okay. This is going to be hard for some of you, I know. All right. So this doorway is called a portal of exit. So I've got a pathogen. It's happy in its home. And if it's forced out, it's going to be through a doorway. Okay. Through a doorway. Now, pathogens don't have wings. They don't have feet. They have no way of getting around on their own. They have to travel in fluid or on air currents. In fluids or on air currents. It's the only ways that pathogens can get around. That's it. They don't have little feet. If I have a pathogen over here, it cannot crawl its way over to you. It's stuck where it's at. Now, if it's small enough and light enough, and it's the right kind of pathogen, it might hitch a ride on a dust particle and be able to spread around. But those pathogens are really rare. Really rare. Like hepatitis, pick a hepatitis, there's like 8, pick one, cannot spread through the air. They're heavy. They don't exit through breath. They're heavy. So hepatitis requires fluid. So if I have hepatitis and you're not anywhere around any of my fluids, you will not get hepatitis. Make sense? Now, the problem is when we have a brand new pathogen, like old pathogens, we know how they get around. We know which ones are spread in the air, like measles, TB, which ones are spread on mucus droplets that are heavy and only fall like 3 feet around the patient. That would be the flu, the common cold. We know which ones travel in body fluids like hepatitis and HIV. We know how those get around. But when we get a brand new pathogen that just shows up unexpectedly and we're not real sure what it is, it takes us a little while to figure out how it gets around. So when COVID first came out, we were like, we don't know. It could be on the air. It could be on droplets. It could be through the blood. We're not sure yet. We don't know. So because we don't know, stay home till we can figure this out. Just don't be around other people. This is a good idea, right? And they had us do things like wiping off our groceries before we brought them in the house. Well, it's because we don't know how this stuff is getting around. We don't know how it's moving. So once we kind of got to know COVID a little bit, we interviewed it, found out its likes, its dislikes, we figured out, okay, it is spread through droplets. Now, droplets means as I talk, little tiny bits of mucus comes out, right? Saliva, but they're heavy. Like they can't spread all the way to you over there. They can't spread to you over there. These little tiny droplets fall about 3 feet around me. So if you're like right in this area and I've got something, then you might come in contact with it. But if you're way over there, you have no chance. This is why we were told to stand 6 feet away from other people. Your 3 feet plus my 3 feet equals 6 feet. You guys see how those recommendations were formed? This is the process we have to go through every time a new pathogen shows up. This is what we had to go through when HIV showed up back in the late 80s. We didn't know how it was spread. Could be spread by air. Yeah, could be. We don't know yet. Could be spread by droplets. Yeah, that could be. We don't know yet. Could be spread by body fluids. Yeah, could be. We don't know yet. We had to get to know it. We had to interview it. We had to take some time with it, find out its likes and its dislikes, its turn-ons, its turn-offs, right? We had to figure it out. Once we figured it out, we said, okay, this doesn't apply. You can breathe the same air, not a problem. You can even be close to somebody, not a problem. This is not how it gets around. It gets around this way. So we gave people recommendations to help reduce their risk. Does that make sense? Good. So we have to understand this whole chain of infection to figure out what precautions to take with which pathogen. All right. So respiratory pathogens, things like measles and TB, are spread in the air. Droplet pathogens hit you right on mucus, and they only go like 3 feet around the patient. And then blood or body fluids carry other pathogens. Nothing spreads through all three, thankfully. We don't have any pathogens that spreads through all three. It's either air, which are thank God for that, very, very rare. This is why measles is such a big deal right now, because measles, all you have to do is breathe. And every breath of air that you walk through, right, is now contaminated with measles. And anybody that walks through that air has breathed in measles. So we actually, during the outbreak a couple months ago, we had a situation where a couple of people, before they ever knew they were sick, because there's like a 2-week incubation period, they would go through an airport. So like all of those people that walked behind that person breathed in those measles, and then they got on a plane, and then they went to different destinations and they breathed. So it spread, and that was kind of sad. So we have to know how things are spread, and thankfully, there's nothing that spreads always. Okay. The airborne ones are the scariest. All right. So we have a pathogen. It lives in a home. It's very happy there. Cable TV. It has to be forced out through a doorway, and then it's got to have a way of getting around. Now, once it gets around, not all is lost. It has to have a way in to another person, because a pathogen on this table is not a threat to anybody. Not a threat to anybody, especially if it's dry, because dry is dead. Okay. Not a threat to anybody. But if I have a pathogen on this table and it's still wet, and I come along and put my hand on it, and now the pathogen is on my hand, still not a threat because it can't drill in. But where is my hand probably going to go in the next couple of minutes? Somewhere up here. And I got all kinds of doorways up here, right? All kinds of doorways up here. That is called a portal of entry. And it's the same doorways that let stuff out. Same doorways. Doorways that let stuff out can also let stuff in. Make sense? Make sense? So if you're going to put any body parts next to any of your doorways, they probably should be clean. Gloves do not accomplish that, and I'm going to explain why in a minute. Gloves do not accomplish that. You need to go wash your hands. For real. Not hand sanitizer. Go wash them. Okay? Now, if those pathogens can't find an open doorway to enter, they just die. Remember, dry is dead. Good? Now, if that pathogen is wet on a surface, and I come along and pick it up and bring it to a doorway, and the pathogen gets inside of me, I'm still not infected. Still not infected. Because I've got one last line of defense, and that's called my immune system. Now, if I have a good, healthy, working immune system, hopefully it'll fight off that pathogen, and I will emerge victorious. Now, I can give my immune system a little bit of help. I'm going to get to that in a minute. But if I have a pathogen, and my pathogen that's now inside of me wins the fight, then I'm infected. And the cycle starts again. Now, so what are some things I can do to keep my immune system, to give it the upper hand, to make sure that it's in tip-top shape to fight off it? Now, remember, as CNAs, we're going into pathogen-rich environments, right? We take the sickest people in the community, put them all under one roof. We know there's pathogens there. We know that there's all different flavors of pathogens here. So I want my immune system to be the very best it can be. I want it to work out a little. Okay? So I don't want it sitting on a couch eating potato chips and getting all flabby. I want my immune system to have a bit of a workout, which means little bits of exposure now and then. Make sense? Good? Okay. All right. So, you know, I had kids, they were younger. I let them go out in the yard and play with worms. I did not wrap them in bubble wrap. I did not keep them safe. I encouraged them to go outside, to get dirty, to do kid stuff, because that built their immune system. Sometimes we go a little overboard in protection, and that puts us at a disadvantage. Okay, so I want my immune system to do a little work. So I'm going to eat that sub. I'm going to eat that sub. It was a good sub. I took those pictures. I ate that sub because I want my immune system to have a little bit of a workout. I don't want it to get all flabby, right? There's a couple other things I can do. I can make sure that I'm getting a good night's sleep or a good period of rest. Because if you aren't resting well, then your immune system is going to be affected. So good rest, self-care. If that means pedicures, then that means pedicures, self-care. Exercise is a huge component of your immune system. And I remember way back when, a million years ago, back before corporations took over all hospitals, hospitals used to have workout equipment for staff. Yeah, for staff. So on your breaks, you could go walk on the treadmill or, do, some exercises, because they understood the connection between exercise and healthy immune systems. And they understood that a healthy workforce produces healthy profits. Okay. So they took those away. So make sure you're getting a good amount of exercise. Make sure you're eating right. We are what we eat. If you're eating a lot of potato chips, they don't help combat pathogens. A few leafy greens thrown in there would be helpful, right? You want to arm your immune system to be able to fight off pathogens. But there's something else that we can do as well to help our immune system be ready for a threat, and that is immunizations. So let me explain to you how immunizations work. Let's say that we have a whole line of bad guys out there. and one of the bad guys storms in through the door, and you're the first person they see. And as they come towards you, you realize they're a bad guy. We got to get rid of them. And you pick up that big pink cup and you bash him over the head. Now, of course, it doesn't kill him, right? But it does scare him off. He runs out the door. You feel good. And they tell the next person in line, hey, there's this girl in a red jacket, and they're going to bash you over the head with a pink cup when you walk in. So make sure you bob, right? So the second one comes in and they evade you. They know it's coming. They bob and weave and they come over to you. Now, you know the cup doesn't work because you saw the cup didn't work. So you pick up your pen and you start stabbing them, and that doesn't kill them. But they run outside and they say, hey, pink cup girl. And then there, there's going to be a pen. So make sure you avoid the pen. So the third guy that comes in avoids you, pink cup girl, avoids you and comes over to you. You pick up that fire extinguisher and you spray them and bash them on the head and you kill them. Awesome job. Thank you for saving us. But in the meantime, all of those bad guys out there know about the pink cup. They know about the pen. Now, they didn't get a chance to learn about the fire extinguisher because we took care of that problem. That dead pathogens tell no tales, right? So this is how immunity works. You have to go through some trials. You have to gather information. And then eventually, something is probably going to work on you. Make sense? Good? Okay, so we have this system, and that's called immunity, where we hit them with a cup, we stab them with a pen, we use a fire extinguisher, we do all these things that we have, all these tools to kill the pathogens before they can hurt us. That's immunity. It's the process of trying all these things to figure out what works. We are not the only ones that have immunity. So do pathogens. So just like those bad guys learned all of our tricks, anything that doesn't work on them, they now know how to evade. This is how we end up with drug-resistant bacteria called MRSA. We threw antibiotics at it, but they were able to overcome those antibiotics. And now they've got a memory of it, so those don't work on those pathogens. If you get prescribed antibiotics, you have to take all of them. Not just enough to make yourself feel better. You have to take all of them. Because if you leave one pathogen behind, one bacteria, just one, it now has the blueprint to circumvent that medication. And we don't do that, right? We take enough to feel better and we put the rest in the medicine cabinet for next time. You just left a whole handful of bacteria that now has your secret plans for annihilation. Make sense? Good. So if you get prescribed antibiotics, make sure you take every single pill, because it's not just enough to make you feel better. It's enough to kill all survivors. All right. So remember that pathogens don't live on surfaces outside the body very long. Let me go here. Pathogens don't get through the skin, okay? So if you wash your hands after you wear gloves, or you wash your hands after all patient encounters, you're removing any pathogens you might have come into contact with. This is why hand washing is the most important step for infection control. And in healthcare, we really get concerned about this, right? Because I don't want to get sick. I don't want to touch you because I don't know what you've got. And we think, okay, we're just going to wear gloves for everything so that I'm not touching you, so I'm not going to get what you've got. And that sounds good on theory. In practice, it's actually a dangerous situation, because when you wear gloves without thinking, you stop thinking about your gloves. Okay? So if I'm just going to touch you, if I'm doing range of motion exercises on you, there's no doorways that I'm going to be anywhere near. I don't need gloves for that. I would just wash my hands before so I don't bring you anything, and I'm going to wash my hands after. so I don't take anything. Make sense? Good? Okay. But a lot of you are like, well, Bo, hold up. That sounds fine, but this. What if I'm touching fluids? What if I'm touching body stuff? I don't want to touch that stuff. So I'm just going to wear gloves all the time, just in case I've got this stuff hanging around. So remember that in order for a pathogen to live, it has to be in liquid, right? If the liquid is dry, the pathogen is dead. You guys remember that? Okay. So if you are going to be around liquid, then yeah, we can use an extra set of protection, just something a little bit extra. But remember that those pathogens cannot get through your skin. So theoretically, I could touch any of these things and go wash my hands because that pathogen is not going to get inside me as long as I don't put my hands up here. The problem is that we put our hands up here all the time without even thinking about it. And that's really the role that gloves play. You think those gloves are there to protect you from this. They're not. That's not why you're wearing gloves. You're wearing gloves to remind you not to do this. That's why you're wearing gloves. Is you would not put a gloved hand on your face. You see those gloves and you think to yourself, oh, I can't put those up here. It's a visual reminder to keep your hands away from your doorways. This gets through gloves. Gets through gloves. I'm going to explain that in a minute. They are not the magic suit of armor you think they are. So with the chain of infection, remember we have to have a pathogen. It has a place to live. It has to leave through a doorway. It has to travel through liquid. It's got to get in through another doorway. That person has to be susceptible in order to be infected. There's a whole lot of steps there that we have to go through for infections to spread. And the way that we stop that from happening is this. Just wash your hands. Wash your hands before you touch somebody. Wash your hands after you touch somebody. And we have interrupted this whole system. Just wash your hands. It really is that simple. Really is. Good rule of thumb here. Don't let stuff from other people's holes into any of yours. It's that simple. Remember, pathogens can't get through the skin. Don't let stuff from other people's holes. If it came out of somebody else's hole, it did not go into one of yours. And yes, that means exactly what you think it does. Don't let stuff from other people's holes into yours. Keeps you safe. Okay. So gloves are an extra layer that we can wear, but they don't do what you think they're going to do. So in order to understand this, we have to think a minute about who those gloves are actually there to protect. Are those gloves there to protect you, do you think? Or are they there to protect the patient? Let's go back to the sandwich for a second, right? We wanted those gloves. We wanted the sandwich worker to wear those gloves because we thought those gloves were going to protect our sandwich. Did they? No. But I said if the gloves were being worn to protect the sandwich worker, they did a good job, right? So we have to go into this with a clear understanding. Who are these gloves there to protect? Now, out of these two, right, me, the healthcare worker, and this person, the patient, which one of us is currently fighting something off? The patient. So their immune system right now, pretty busy. My immune system right now, pretty healthy. So which one of us is at risk? The patient. Now, obviously, I don't want any of what the patient's got. I get that. I'm with you on that. I know how to prevent that. I just wash my hands before and after, and I don't put my hands near any of my holes. I know how to prevent that. I don't need gloves to prevent that. Does that make sense? Everybody with me? All right. My immune system is currently pretty healthy and on standby. No. But my patient's immune system is not. My patient's immune system, unfortunately, pretty busy at the moment, fighting off whatever's trying to kill them. So if I'm working in a setting that I know has a lot of pathogens, and I know my patient is the one that's truly at risk, then I have to think about infection control from that standpoint. Okay? So basically, we have to be aware of what those gloves are touching. When I was talking to you about the sandwich, and we were going through step by step, about halfway through, most of you guys figured it out. You guys are like, wait, hold up. She's touching the drawer. She went to the cooler. She's touching the, oh my gosh, I don't want to eat that sandwich now, right? You figured it out about halfway through. Well, when it comes to working in a healthcare setting, it's a whole lot more impactful than just germs on a sandwich. This is life and death. Truly, life and death. So if their immune system is currently fighting off whatever's trying to kill them, who's going to be around to fight off these new invaders? Truly, life or death. Remember, as far as you're concerned, any pathogens have to use a doorway to get in. That also applies to the patient, though, right? If we bring pathogens to that patient, they have to get in through a doorway. And with patients, oh boy, they have a lot of doorways that we as CNAs are around. We help patients with toileting. That's a doorway. We help patients with grooming. That's a doorway. We help patients with bathing. Oh, lots of doorways there, right? Feeding. We help patients with all kinds of things, and we're all around. We are around more doorways than the nurses are, than the doctors are. Make sense? So we have to understand this and work on ways to prevent spreading infections, new infections to our patients. These are all of the doorways and all of the skills that affect those doorways. And this is why it's so important for CNAs to understand this. So yes, you are at minimal risk. Your patient is at maximum risk. So if we understand that, we see gloves in a little bit different light. And remember that any new pathogen your patient may not have the ability to fight off. So let's talk about these gloves. We are going to wear gloves if we are going to be working around any of these areas because we don't want to bring pathogens to those doorways. Remember, I'm going to wash my hands before and I'm going to wash my hands after, and I'm not going to put my hands near my face. So any pathogens I might come into contact with are going to go down the sink. But if I'm going to be working around any of these areas, I may be bringing pathogens to the patient. And that's a bad deal for the patient. So if I'm going to be working around any body fluids, personal skin, or non-intact skin, I'm going to wear a set of gloves. Not as much to protect me as to protect the patient, because I don't want to bring things to the patient's doorways. Does that make sense? Okay. All right, this is called standard precautions. Now, it's also called universal precautions. You'll hear it both ways. But this is the theory that you can't tell by looking at somebody whether they have a pathogen. Like, I can't look at you and say, yep, hepatitis, yep, TB, yep, measles, yep. I can't do that. You can't look at somebody and just tell exactly what they've got. We don't have these little LCD screens on our forehead yet. So we have to treat everybody like they have something that we could pass around. So if I'm going to be working around any doorways, I need an extra layer of protection, and that's why we're going to wear gloves. Okay. So if we're going to touch any non-intact skin, body fluids, or personal skin, we're going to need a set of gloves. It applies to everyone. If we do decide to wear gloves, the first thing those gloves should touch is the patient. Not the supplies, not the curtain, not anything else. And somebody actually said this on Monday. Wait, what about gloves? When I was talking about supplies. So we don't walk in the patient's room, do our opening, wash our hands, and put gloves on, Because if we do, then everything we touch in that environment with those gloves is going to contaminate the gloves and take that contamination to the patient. The first thing those gloves should touch is the patient. So we get our supplies, we get everything prepped, we get it all ready, and then right before we start our skill, that's when we put our gloves on. Good? Good? All right. Once you've touched that patient, you have to be aware of what your gloves have touched in the environment so we're not spreading contamination around. And then we're going to remove gloves correctly. But before I show you how to remove your gloves, let's talk about gloves because they're not the magic suit of armor you think they are. People put gloves on and they think, okay, I'm safe, I'm good. They think those gloves are there to protect them. They're not. They're not. Those gloves are there to protect your patient, not you. And just like the sandwich, we have it backwards. Now, why aren't those gloves there to protect you? Well, you guys have all seen party balloons like this, right? We fill them up with helium. They bop up against the ceiling for a while. What happens to that balloon after a couple days? It deflates. It shrinks. How does that happen? How does that happen? This is physics. That same material makes our gloves, that latex, same material makes our gloves. And when you blow up a balloon, that balloon stretches. And what makes up the material, the latex material, it looks solid to us. If we like looked at it, it would look solid, but it actually has little teeny tiny microscopic holes in it. And as we blow up that balloon, those holes stretch. And over time, the helium is able to wiggle out through those holes. And that's how the balloon shrinks. That helium actually gets through the surface of the balloon and it shrinks. Well, our gloves are made out of the same thing. Same thing. Same latex. So we know that gloves have holes in them. If helium was allowed to escape through those holes, you think pathogens are going to have any problems? No, they're going to get out through those holes too. So you put gloves on and you think in your mind, I'm safe. I'm safe. You put those gloves on, you do your work, whatever it is you need to do, you take those gloves off and you don't wash your hands because you think I'm safe. You aren't safe. Those pathogens got through those holes. We have done a million. If you ever take microbiology, you'll do this activity. Go wash your hands really well, as good as you can. Do the best hand washing you've ever done. And we're going to put a Q-tip on your cotton swab on your hand, and we're going to culture it. We're going to put it on a little Petri dish, and we're going to put it in a incubator and let it incubate for 3 days. Now, I want you to put on a pair of gloves and I want you to do something. Cut up some raw chicken. Now, you've got gloves on. You're good. No problem, right? You think you're safe. You take those gloves off. I'm going to take another cotton tip applicator and I'm going to scrape it on your skin and I'm going to put it on a Petri dish and put it in the incubator for 3 days. Now, ideally, when we come back 3 days later and we look at those experiments, right? The first one shouldn't grow anything because you just washed your hands. Best hand washing you've ever done in your whole life. That Petri dish should be absolutely empty because it's the best hand washing you've ever done and it's growing stuff. Oh my gosh, it's growing a lot of stuff. Like there is like trees growing on that thing. You thought you got everything off of your hands. You didn't. Stuff growing. Now, let's look at the other Petri dish, though. This is where it gets interesting because you put gloves on and you thought, okay, well, if the first one grew stuff, the second one's probably going to grow stuff, but it should be the same stuff because those gloves protected me. When you look at that one, there will be all kinds of new pathogens. Stuff gets through your gloves every time. Those gloves are not a magic suit of armor. Now, I go to I go to a store and there's always this little lady cashier who's got gloves on as they're checking you out because they don't want to touch your ketchup bottles. right? So they're sitting there for 4 hours and they're just scanning stuff and they have their gloves on. And at the end of 4 hours, when it's time for their break, they take those gloves off and they go to the break room and they eat their sandwich because they think to themselves, my hands are clean. And they're not. They're not. It would have been better for them to not wear the gloves at all and go wash their hands before they ate. There would be fewer pathogens that way. Now, here's the other problem with gloves is they make your hands sweat. Have you ever worn gloves? They make your hands sweat. And that produces a warm, dark, moist environment, which is where pathogens breed, proliferate. So not only do we have pathogens that got through the gloves, they multiplied. And if you didn't wash your hands, you're now bringing those pathogens up to your face if you're eating, drinking, talking, talking on the phone, or you take them to another patient. Do you guys see why gloves can actually be way more dangerous if we don't understand how they're used properly? Now, I'm old enough to remember back in the 80s, staff members were not allowed to wear gloves. There weren't even any gloves in the hospital. The only gloves that you could get were in surgery and at the nurse's station for invasive procedures. But just day-to-day care, there were no gloves. There were no gloves because we understood that hand washing, wash your hands before, wash your hands after. This is the purpose of infection control. But then HIV came along and we didn't know. So gloves became normal. And then throughout the decades since, gloves have just become a normal routine part of healthcare. But they actually put you more at risk if you don't understand how to use them properly. Does that make sense? All right. So we're going to learn how to remove gloves correctly in just a few minutes. But first, we're going to take our break. So we're going to come back in 15 minutes. Okay. Okay. So if you turn in your books to page 43, you'll see instructions on how to remove your gloves. So on your desk, on everybody's table, are gloves. Go ahead and grab a set. And put them on. Yeah, there's different sizes. All right, there is a right and wrong way to take gloves off. Dirty glove can touch dirty glove. This is fine. Dirty glove cannot touch skin. So you cannot go underneath. Be very careful about that. They're actually watching for this on the state exam. If you wear gloves for any skill, then they're going to grade glove removal. So in order to take a glove off, you're going to pinch up near the cuff, like at the palm of the hand, not underneath. Be really careful not to let your thumb touch your skin. So pinch up and pull off. And then you're going to wind this one up in the palm of your hand. Doesn't matter which one you do first, but pinch up and pull off. Now, skin can touch skin, no problem, but I cannot touch the outside of this dirty glove. So for this one, you're going to go underneath. So one inside out glove is inside the other inside out glove. Yep, you don't want to touch the outside of the glove at all. Be very careful about that. Yep.
Got it.
Okay, very good. Okay, and you can throw those away. Most important step of glove removal is washing your hands to remove any pathogens that got through. Now, you don't have to wash your hands immediately. Like you don't have to take the gloves off and go straight to the sink and wash your hands. You can finish up with the patient because remember, it's the patient's cooties, their own cooties. So it's perfectly okay to do your closing, open the curtain, give them their call light, get everything done, and then go wash your hands. But you need to wash your hands before you go to the next patient. Okay, good, makes sense? The biggest thing is don't wear gloves and think that gets you out of hand washing. Do not rely on those gloves to keep your hands clean. Only hand washing can do that. So glove rules apply to every single skill. We wear gloves if we might touch body fluids, personal skin, or non-intact skin. The first thing your gloves should touch is the patient. That keeps those gloves clean for the patient. Once you've touched the patient, the gloves are dirty, so pay attention to what you touch with those dirty gloves. Don't cross-contaminate the environment. And then remove your gloves correctly. Good? Flashcards have all of those principles on it. All of the principles are in here. You can make your own flashcards. If you choose to get ours while you're enrolled in the program, they're only $14.99. So now we're moving on to Pulse. This is our first skill that we're going to learn. Yes? Okay. Miss Patty, I'm taking my CNA exam in 20 minutes. What are some good tips? Follow the care plan. Focus on the patient. If the care plan tells you to do, let's say, range of motion, only do the exercises that are listed on the care plan. If the care plan tells you to ambulate a patient, only ambulate them as far as the care plan says. If they have you transfer a patient from bed to wheelchair and it says the patient cannot take steps, make sure the wheelchair is close enough that you can transfer without taking steps. Just follow the care plan. But make sure you're focusing on the patient. Talk to them. Let them know what you're doing, but you'll be great. Good luck. Let us know how you do. All right, so if you look on page 52, this is our overview of this skill. You see all of the principles involved listed here, and they're all detailed here. This is test-specific steps that we're going to go over in class together. This is the short version of the skill. I have a video for this. And then down here is test specific information. So somebody with your level of experience should be able to do this skill in 5 minutes or less. This is going to be done on another testing student. That person will be positioned in bed at the beginning of the skill. This is a charting skill. You do have to document. Normal values are between 60 and 100, and you can be off by 4 beats in either direction and still be accurate. Let's take a look at our step-by-step instructions on page 53. At the top of the screen, you see the care plan for this skill. The care plan tells us the patient will be lying in bed for the skill. Take the patient's radial pulse, measured at the wrist, for 1 full minute and record your readings. So it tells us what pulse to take, where it's located, how long to count, and to document. We have to do each of those things. So one of the mistakes that's made on this skill quite often is that students will try to get fancy. They'll whip out a stethoscope and listen to the heart to take the pulse. That's called an apical pulse. And it's sometimes used. But that's not what this care plan tells us. What does this care plan tell us? What pulse are we using? The radial. So if you use any other pulse point in the body, you have failed because you did not follow the care plan. It's not about showing how much you know. It's about showing that you can follow directions. So be careful there. Follow the care plan. Make sense? Now, luckily for us, this care plan actually tells you where that radial pulse is located. They're not going to expect you to know, the names of all the pulses. So this care plan takes it a step further and tells you where that radial pulse is. And we're going to go over that in just a minute. It tells us to count for 1 full minute. Now, that's important. This care plan, for whatever reason, needs us to count for 1 full minute. So if we take any shortcuts here, we're not going to pass because we're not following that care plan. We'll go over the shortcuts in just a second. So here's that care plan listed out. We're going to use these steps to accomplish that, along with our opening, our glove rules, and our closing. All right, this is our checklist for this skill. Okay, so when you go take the test, this is what they're grading you on. All of the steps that they're grading you. All of those steps. We're going to use these principles to get all of those checked off. I'm going to show you how to do that. All right, so we already know all the principles involved in this. We know to follow the care plan. We know to do our opening. We know to evaluate if we need gloves. Now, we probably won't need gloves for this skill. We have to figure out, am I going to touch body fluids when I do this skill on this patient? Well, for the exam, your patient is another testing student. They're all fully clothed and holding on to all of their own body fluids like a champ. So your chances are you're not going to be around any body fluids. You're certainly not going to be around any personal skin for this. You're at the wrist. This is not personal skin. Okay, good, makes sense? So chances are for the test, unless they have a big old cat scratch that's on their arm, you're not going to be needing gloves for this. Make sense? Now, if I were taking the pulse of a patient who had shingles on the arm that I was taking the pulse on, shingles is like a weepy rash. Would I need gloves for that patient? Why? Right, because I'm now touching open skin. Does that make sense? Okay, so gloves are not based on the skill. Glove use is based on the patient you're doing the skill on. Good? Makes sense? All right, we know to do the opening. We know to follow glove rules, and we know to do the closing at the end. So what we need to learn are the steps related to this particular skill, and we're going to go through that now. So on the left side of your chest, you've got a heart. That heart squeezes. When the heart squeezes, it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it. And that wave pushes the one in front of it. And this is how blood moves through your circulatory system. Waves and valleys, waves and valleys, waves and valleys. And all I'm going to do here is push down on the artery so I can feel those waves moving through the artery under my finger. That's what I'm doing. And my care plan tells me how long to do that for, to count. How long am I counting? 1 full minute. For the test, there's a clock right above the bed. So you're going to use that clock to time yourself. 1 full minute. If you want to wear a watch, that's fine. You can do that. Now, if I count the waves, that tells me how many times that heart contracted over that minute. It's an indirect measurement of the heart rate. The wave is only produced because the heart contracted. So if I count the waves, I know how many times the heart contracted. Make sense? Good. All right. So a good visual for this so that you can kind of understand what's happening on the inside of the artery is let's talk about a garden hose. You got a garden hose attached to outside your house, attached to a faucet. Everybody have one of these? Familiar? You've ever seen a hose attached to a faucet? All right. So if you go out to that faucet and you turn it all the way on, water comes through the hose expands, it gets bigger, it gets harder, there's pressure inside, water pressure. Turn that faucet off and the water slows down to a trickle and then goes away. The hose shrinks, it gets softer, less pressure inside. Good? So when you turn the faucet on, more pressure inside. When you turn the faucet off, less pressure inside. Everybody got that? That's all that's happening inside your arteries. The heart squeezes, it pushes out a wave of blood. We turn the faucet on. And then the heart relaxes and the faucet goes off. On, off, on, off, on, off. And this is what makes those waves. So if I go back out to that faucet and I just stand there and go on, off, on, off, on, off, you know what would look like in the hose, right? You'd have little water, no water, little water, no water, little water, no water. That's what's happening on the inside. This is going to be important when we get to blood pressure next week. Okay, so all I'm going to do is take 2 fingers. I'm going to push down on that artery, and I'm going to feel those waves as they move through. It's not a constant sheet of blood moving through. It's waves. That's what we feel when we feel a pulse. It's those waves. Good? Make sense? Now, everybody's waves are going to feel a little different. Some people, super easy to feel. They're like, boom, boom, boom. They're there. Other people have a very faint pulse, and it's more like, kind of hard to pick up. So we're going to start light. So we put our fingers there. We start light, and we gradually increase our pressure deeper and deeper and deeper and deeper until we can feel those thumps. Good. So we start light, and we gradually increase until we pick up the thumps. On you, I might not need any pressure at all. On you, I might need to press a little bit. Everybody's a little different. Got it? Got it? All right. We never, ever, ever use our thumb to take a pulse. Your thumb has an artery in it. When you press down on that artery, you'll actually feel your own heartbeat, so it doesn't help us. We use 2 fingers. I want to use the fingertips, not the flat part of my fingers. Fingertips. 2 fingers, never the thumb. Good? All right. So we get our fingers in place. We start light, gradually increase our pressure until we feel thumps. And we put our thumb on the back side of the wrist. So our fingers are in a C shape. If I just take 2 fingers and set them here, I might feel my thumbs. Like right now, I can feel my thumbs. But how long do I have to count for? 1 full minute. That's a long time. So over that full minute, my fingers are going to relax, and I'm not going to have any control over it. They just will. So I'm going to lose the count. And that's what happens is you put your fingers there, you feel it, you start counting. 32, 33, 34, 30. It's gone. What happened to the pulse? Nothing happened to the pulse. Something happened to your fingers. So we put our thumb on the back side, and this C shape holds consistent pressure, and it keeps you from losing the pulse. So we put our fingers there, press down until we can feel the pulse, put your thumb on the back side to hold it steady. Good? And then we're going to count. Whatever number we get to in that minute is whatever number the pulse is. So we look at the clock, we pick a starting point, wherever you want to start, and you say out loud, start. And then you count the thumps you feel under your finger until that second hand gets all the way around to that starting point. Okay, good, good. Now you can start on the 12, but if I'm going to start on the 12, that's a whole lot of time to just sit here. And start. That's a long time to just sit there. So you can start on any number. You can start with the second hand on the 2. Start. You can start on the second hand on the 4. Wait till it gets there and say start. You can start with that second hand on any number you want to start on. But you just have to make sure that you count until that second hand gets all the way around to that number again. Now, this can be a little bit hard because you're counting numbers and you may not remember what number did I start on, right? So I make this hand is taking the pulse, right? This hand is on the wrist. I make this hand remember what number I started on. So if I start with it on the 1, I do this. Now I know my finger is telling me which number I started on. If I start on the 5, I do this. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And that way I always know what number I started on. Now I'm free, my brain is free to count the thumps that I'm feeling. Normal is between 60 and 100. That's what we're hoping we get, somewhere between 60 and 100. If I got 48, what would I do with that number? Tell the nurse. If I got 120, what would I do? Tell the nurse. That's right. So if it's between 60 and 100, it's considered normal. We document. If it's anything outside of that, we would have to let the nurse know. Tell the nurse. Okay. Questions? When you're taking the pulse, you want to make sure that the elbow is supported on the bed. Don't have the arm just kind of hanging out there in midair. When an arm hangs out there, that means that these muscles have to be engaged to keep the arm in this position. For these muscles, these are big muscles. They require a lot of fuel to contract, which means that my heart rate is going to have to go up to push more blood to this area to hold the arm up. It's going to affect our heart rate. So you want that elbow supported. You can lift the lower arm. That's fine. I can do this. That's fine. But if I lift the elbow off the bed and these muscles have to engage, then I'm going to affect the heart rate, which is no good. Good? So elbows have to be supported. All right. You want to use 2 fingers, not your thumb. Your thumb is on the back side, not the front side. So I'm going to use 2 fingers, fingertips, and that is a graded checkpoint. Remember, fingertips have more sensitivity. So where is the radial pulse? Let's talk about that now. So if you hold your hand out with a thumb pointed up like you're about to shake somebody's hand, okay? So hold your hand out with a thumb pointed up. Right along here, you have a bone, right at the top of your wrist. Now we want to be at the bendy part of the wrist, not down here. You want to be where your lines are. So as your thumb comes off of your hand onto your wrist, you're going to take 2 fingers. You're going to stand it up on that bone like you're going to dive off a cliff. And then you're going to roll forward and put your thumb on the back. And you should be right on top of your thumbs. You should be able to feel thumps under your finger. So there's a bone there. We stand up on our bone, we roll forward, and we put our thumb on the back, and you should feel your thumps. Go ahead and try to find your thumps. Put your thumb on the back. Did everybody find theirs? Anybody having trouble? Relax your wrist a little bit. If it's too stiff, that tendon can override your. Did you find it? Okay, so you're a little too far down. Remember I said we need to be at the lines? So you want to be.
Like that.
Yeah, we're going to stand our fingers up, stand up, roll forward, thumb on the back. Maybe a little bit further up here. Yeah. Feel it?
I think so. I don't know.
Press a little harder. Here, let me see. Relax for me. Right here.
Okay. Yeah.
Got it? Did you find it? Okay. Okay. You're a little too far up here. It's going to be right here, right there under my fingers, right there. Put your thumb on the back. Feel it? Come on, relax a little bit. There we go. Okay, let me find it.
I can't feel nothing.
Okay, I think you're pressing a little too hard. Do you feel how hard I'm pressing here? It's right here under my finger.
Oh, I feel it now.
Got it? Did you find it? You're a little too high here. We're going to go. We stand up on that bone and then we roll forward. So see where your fingers are? They're not actually on the bone. They're just below it. You feel it?
Sure.
Got it? Okay. Did you find it?
I caught it and I caught it for 1 minute.
Okay. Did you find it? Did you find it? Find it? Okay. All right. So find somebody else's. Grab a partner. Find somebody else's. Find somebody else. If you're right-handed, use your right hand. If you're left-handed, use your left hand. Use your dominant hand.
Okay, so I'll say I don't know if I feel it, but I think right here,
Okay.
I feel like the thumb thing.
Yep, that's what you're looking for is that thumb.
Okay.
Yeah, hers is just a little bit more that way. You probably feel a little better.
Yeah, I felt
Right
a
there.
thumb, but I wasn't sure. If it
Yep,
was-
the thumps are what you're looking for. Okay. Good.
Found it. That was easy. I got it.
Got it? Okay. Were you able to find one? Okay, good. All right. So putting your thumb on the back side is important because that's going to hold that consistent pressure so you're not losing the count, because otherwise you're going to lose it as you're counting. So all pulses are reported over 1 full minute, but that doesn't mean we're always going to count for 1 minute. It depends on our care plan. Sometimes if our care plan doesn't say we have to count for a whole minute, sometimes we just count for 15 seconds and then multiply that by 4 to get our full minute. We can only do this if the pulse is regular and if the care plan allows it. So this is kind of a time saver. Very common in a clinical setting. As long as we have a pretty healthy patient, their pulse is regular, this is probably what you're going to end up doing. You can also do 30 seconds and multiply that by 2, but this is more standard. And this is why we multiply it by 4. If this is 15 seconds, I have 4 of those in a minute. So I count for this, and then I multiply that by 4 to get my full minute. It's a shortcut. But we can't do that for this one because our care plan actually tells us to count for 1 full minute. Okay. Remember, normal pulse rate is 60 to 100. And we're going to document this because anything that we report or anything that we measure, we must report. Okay, so we're going to use all of these principles to check off this checklist. So let's go through this really quickly. We are going to follow our care plan and get these check marks. We are going to do our opening and get these check marks. We're going to decide if we need gloves and get this check mark. We are going to count for 1 full minute using our fingers, not our thumb, at the wrist and get those checkpoints. And then we're going to do our closing and get those checkpoints. So all together, when we do all of those steps, we end up with all of our check marks. Make sense? Good? Good. Remember that this care plan, the one that we just read, is only for this patient. This one's going to have a different care plan. This one's going to have a different care plan. This one's going to have a different care plan. This care plan is only for this patient based on her specific needs. Make sense? Good? Okay, Jake, can you show us the video for measure and record the pulse? Now, when we put this video on, you're going to see at the bottom of the screen, it's going to say count with me. Okay. And when that happens, when I start counting, the words are going to get bigger and smaller. Those are the thumps that I'm feeling under my fingers. So you can actually on the screen watch and count those. So 1, 2, 3, 4. That's a visual of what I'm feeling under my fingers as I'm counting. And see if you get close to the same number that I get. Okay.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to take your pulse. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and I'll be right back. Okay, now that I've washed my hands, I'm going to elevate your forearm, keeping your elbow on the bed. I'm going to find the pulse, which is on the thumb side of the wrist. 2 fingers, thumb on the back. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? Pick a starting point on the clock. Ready, set, start. Stop. Thank you very much, Mr. Jones. Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Here's your call light. If you need anything at all, just press that red button and we'll be happy to help you. I'm going to go ahead and open the curtain. The bed is in the low position. I'm going to go wash my hands. In Florida, you would count with the second evaluator at this point. For the purposes of this demonstration, I'm going to document and wash my hands. After washing my hands the final time, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right. Any questions on pulse? This is one that you can practice at home if you have anybody laying around. Just make sure they have a pulse. But you can practice this one at home pretty easily because it's, it doesn't really require any input from anybody. Make sure when you're doing this that you're doing the opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. Well, your name, not mine. I'm your CNA today. I'm here to take your pulse. Is that okay? Let me close curtain, wash hands, and I'll be right back. And then count the pulse. And then, thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Your environment's clean. Bed is in the low position. Would you like anything before I go? Here's your call light. Open the curtain. Wash your hands, document, and wash your hands again. And all of you can just use a pen and paper to document. Okay, good?
So for instance, what do you document down after counting the polls?
The number that you got.
Okay,
So what did you get when you were counting the words on the screen? Did you count them? Do you remember what you got?
I remember I picked the number. I picked 5, just to be sure I got the 1 minute correct. But then the number.
I got 71.
Okay, and on the video, I got 72. So you can be off by 4 beats in either direction. So I got 72. So if you got 68, 69, 70, 71, 72, 73, 74, 75, or 76, you're considered accurate.
Okay, so I picked 5 to, how do you call it, to help me know it's
Well,
2 minutes.
on that video, I actually started with the second hand on the 12. Okay, so when I said start, that's when I started counting. That's when you should have started counting too. So you pick a starting point, and then when that second hand goes all the way around to that starting point again, then that's a minute. So for instance, right now, let's just give it a second here. Let's say I start with the second hand on the 2. Okay, and I would say start. Now I'm going to count what I feel until that second hand gets all the way around to that 2 again. That's a minute. Okay. Good. So during the exam, you get to decide when you're going to start counting. But you're going to say start out loud because on the other side of the bed is the evaluator. On the other hand, they have to start counting when you do. If you don't tell them when you start, they don't know when to start counting because you want the same number. Okay. Good. Good. All right. So now we're going to learn how to dress a resident with a weak arm. So this is on page 102. If you look down the side here on page 102, you can see all of the principles that are involved in this skill, and they're all spelled out for us here. And if you notice, there's a couple of new ones that we don't know yet, so we're going to have to learn those. This is our short version. We have a video for this. And down here, is test-specific information. Somebody with your level of experience should be able to do this in 14 minutes or less. This is going to be done on a mannequin. This is our first mannequin skill. And that mannequin will be laying in bed. Charting is not required on this skill, so we don't have to document anything. We're just going to follow the care plan and do what it says. Good? Questions so far? No? All right, so page 103 has our care plan at the top of the page and step-by-step instructions. So you can actually take this book home to any live person that you have lying around. Find one. As long as they can read, they can help. You hand this book to your live person and you tell them, read these steps to me and then wait for me to do them. So they read step number 1 and it says read care plan. So read the care plan. Knock. So, and then they read greet resident, identify by name and introduce self. Hi, Ms. Jones. My name is Patty. I'm your CNA today. And then they read explain procedure to resident and get consent. I'm here to get you dressed. Is that okay? So you can practice. It's called guided practice. So they read the step, you do the step. That way you make sure that what you're practicing is correct. It follows the steps. Does that make sense? Now, once you do a skill once that way, you shouldn't need that anymore. Then you ask them, okay, don't read the steps to me now. Now I'm going to do the skill. You just read along and tell me if I missed anything or help me out if I get stuck. Make sense? When you're practicing in here, remember I said there's no practice first 2 weeks. When you're practicing in here a little later on in the program, you should be practicing in groups of 3. One person is the patient. Now, we don't need a patient for this one because it's a mannequin. One person is the CNA, the one doing the skill. The third person should have the book and be reading along to make sure that the CNA is doing the skill correctly and to help them if they get stuck. Now, I can do that. I can help you. But in that scenario, everybody is learning. If I'm giving you the answers, nobody is learning. Does that make sense? Okay. So the best way to practice is for one person to be the patient. They're learning. They're learning what it's like to be a patient. One person is doing the skill, and one person is prompting the skill and ensuring everything is done right. If you do that for every skill, you will get 100% on the exam. That is the best way to practice. Good? Questions? Okay. Now, at the bottom of the page, you can see the supplies for this. Now, there's not very many supplies needed. We need a privacy blanket, we need clothing, and we need a barrier to put them on, which we're going to talk about in a minute. But you have to learn supplies. As a nurse, I'm not going to ask you, hey, will you please go get that patient dressed? And you'll need to take with you a barrier, a privacy blanket, and clothes. I'm not going to do that. I'm going to say, hey, go get that patient dressed. You're expected to know what you need to accomplish that. This is often the hardest part of the exam for students is learning supplies. So now would be a great time to start making your flashcards for supplies. Okay. Hold on one second, sorry. All right. So here's our care plan for this skill. Dress the resident in a long sleeve, button front or snap front shirt, pants, and socks. We're going to stop there for a second. Let's look at each one of those criteria individually. Long sleeve. Anybody been outside lately? It's hot. and it's only getting hotter. So your brain might think, oh, it's hot. I'm not going to put long sleeves on that patient because it's hot. What does our care plan say? Do we get to override that care plan? Do we get to think?
Yeah.
No. So if the care plan says long sleeve, what are we using? Sleeves. Very important because long sleeves are used for more than just temperature. And a lot of CNAs don't know this. There are some patients that have something called dysautonomia or dysautonomic regulation, which means that they can't regulate their body temperature the way you can. And we have to use clothing to keep them at a consistent body temperature. And that's why, even though you might feel it's hot, we may need long sleeves. Make sense? Good. There's also some conditions that have what we call photosensitivity. What that means is the condition gets worse with exposure to sunlight, UV rays. We don't want that patient to have a lot of skin exposure to UV rays. So in that case, we may have long sleeves ordered for the patient to help protect the skin from exposure to UV rays to prevent the condition from getting worse. This is often common in autoimmune diseases like rheumatoid arthritis and lupus and Sjögren's disease and others. So long sleeves are not just for temperature. They can also be used if to cover skin openings. So if the patient has shingles on their arm, we may want them dressed in long sleeves so they're not having weepy open rashes exposed to others. So if a care plan says long sleeves, you don't get to override that, no matter what you think. Now, if you're concerned about temperature, who would you take that concern to? The nurse. That's right. That's right. I worked with a CNA one time, long time ago, who it didn't matter what I put on the care plan. She put the same thing on the patient every day. And I'm like, the care plan. And she says, yeah, but it's hot. I don't care what you think, the care plan. And she never did get it. Never did get it. Don't try to reinvent the wheel. Just follow directions. Okay. Now, the next part of that, so we covered long sleeve. The next part of that says button or snap front shirt. So let's stop there. Button or snap front shirt. If the patient has a weak arm, a weak extremity, they had shoulder surgery, they had a stroke and one side is affected, they have an injury. If they have an arm that does not have full range of motion, we don't dress them in pullovers. We don't dress top down. We dress side to side. Now, we're used to wearing top down stuff, right? So almost everybody is in t-shirts or something that you pull over your head. That's kind of our norm. But in order to put on a pullover, you have to be able to extend both of your arms. If we have a weak arm, that's very hard to do, especially one that's had surgery or maybe is paralyzed from a stroke. So in that case, we tell the family or we tell the patient, go get shirts that fasten up the front, button front, snap front, whatever. And then we dress side to side and we do it in a very specific order. We're going to go over in just a few minutes. But the way that we're going to set this up is that the old garment's just going to slide right off that weak arm, no movement required. And the new garment just slides right up that weak arm, no movement required. So it reduces the impact on the patient. Make sense? But we need to, if the care plan says button or snap front shirt, we need to comply with the care plan, not try to force this patient into a pullover. Now, for the exam, it also says pants and socks. We don't care about those. We're going to put them on the patient, but no special order necessary there. But for the exam, you're going to have clothing like this, all put together in one little cubby or one shelf, right? You've got everything kind of jumbled together. Your care plan's going to say this, okay? You're going to ask the patient, what do you want to wear today? And the evaluator, because remember it's a mannequin, The evaluator is going to describe an outfit, my blue pants and blue shirt. You're going to say, okay. Now, when you go to this little cubby, you better find the outfit they described, and you better make sure that it's a button or snap front and long sleeves. Because there are some evaluators that will put, let's say that I want my blue pants and blue shirt. There will be a blue short sleeve shirt up there. Pull over. So make sure that you're complying with that care plan. Super important. Good? Good. All right. It says the resident is lying in bed and has a weak right arm. Which arm is weak? Right arm. We need to know that. You're going to have to tuck that in your brain. You've got to know which arm is weak. Super important for 2 reasons in this skill. It says the resident is not able to help with dressing, and after dressing, leave the resident in bed. Normally, if we get somebody dressed, we're getting them out of bed to go somewhere to do something. If they're staying in bed, they're going to stay in nightgown. But for this skill, at the end of the skill, just leave them in bed. That's what our care plan tells us to do. This is our checklist. Do you guys see how many checkpoints are on here? It's a big checklist. There's a lot of points that we have to get marked off here. Thankfully, we know quite a few of them already. I'm going to show you that in a minute. But there are some we don't know. So we know skill rules, follow the care plan. We know how to do our opening. We know to evaluate if we need gloves. And we know how to do our closing. But there's 3 principles that we don't know yet, and we're going to learn these right now. So the first one we're going to learn today is the barrier. Now remember, principles are things that are not on the care plan. These are things you need to know. So the first one we're going to learn is the barrier. This is going to be on page 84 of your book. And we use this principle on a whole lot of skills. Do you see how many skills this is going to apply to? We're going to use a barrier on almost every skill. Notes for this are on page 85, so you don't have to take notes. During the exam, you need a place to put your supplies, right? We have to get supplies, and we're going to need a place to put them. Now, this overbed table is what we're going to use for our supplies, but this is not clean. This has had chapstick and food trays and probably little juice boxes and crossword puzzle books and phones and phone chargers and all kinds of stuff on this table. It's not clean. So in order for me to use this, I have to make it into a clean surface. To do that, I'm going to use something called a barrier. So a barrier can be anything. A barrier could be a paper towel. It can be a bath towel. It can be a Kleenex. It can be anything, can be a barrier. But for the test, we're going to use something very specific. This is the type of barrier we're going to use. This has another name. It's called a disposable underpad. More commonly, it's called a chucks because it's a type of underpad. We chuck it when we're done with it. There's another type of underpad that's a washable pad that goes under the patient that we call a bed pad. So the washable underpads are called bed pads. The disposable underpads are called chucks. We're going to use this as our barrier. Now, the reason we're using this is because it's waterproof, so anything that leaks through isn't going to contaminate our table, and it's absorbent, so it will absorb anything that might leak and keep it from going on the floor, okay? So this is a chucks, and that's what we use as a barrier for the state exam. But remember, anything can be a barrier. So when we're doing our skills, you cannot get your supplies until after you've washed your hands. Remember our opening? Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? Let me go close your curtain, wash my hands, and then get my supplies. You guys remember that order? It's very important that we do that in order, because we can't touch those supplies. They're going to be used on our patients until our hands are clean. It's just like our patient, right? We can't touch the patient until our hands are clean. Can't touch the supplies until your hands are clean either. Make sense? Okay. So we do our opening, we wash our hands, and then we come over to our supplies. But we need to have a clean place to put those supplies before we get them. So we wash our hands, and then we go get the barrier to put it on the table. And then we go get the supplies and put them on the barrier. Now, the reason it has to be done in that order is you can't hold supplies against your uniform. Your uniform is not clean once you start work. It's kneeled on the floor. It's leaned up against the bed. It's brushed up against the curtain. It's leaned against the sink. Your uniform is not clean once you start work. So we don't want to hold those supplies up next to our uniform, which can contaminate them. I need 2 hands to spread that that barrier on the table. If I hold those supplies against my uniform to spread the barrier out, it's going to contaminate the supplies. Got it? So we wash our hands. We go get the barrier. We put the barrier on the table. And then we go get our supplies and put the supplies on the table. Good? Make sense? That keeps your supplies clean for using. Questions on barrier? You just learned a whole nother principle. But that was way easier than opening and gloves and closing. Good? Good? Questions?
When you say barrier, I was thinking about like a cream.
Oh, yeah, you're talking about a barrier cream. Yeah.
Like when you said barrier, you talk about the pad. That's to put down.
So the term barrier in healthcare means separation. That's all it means. Now we can use a chucks as a barrier to separate clean supplies from dirty surface. We can use a cream on a patient to separate fluids from skin. But the term barrier just means separated. Okay. And yes, we do use the term barrier cream. All right. So we get the barrier first. You put the barrier on the table. You get your supplies and put the supplies on the barrier. So now we know barrier. Let's move on to privacy blanket. Now, privacy blanket is used for more than just privacy. It's used to keep our patient warm and provide privacy. A lot of people think that the privacy curtain is enough for privacy, and it's not. That privacy curtain blocks your view of the patient, all of you guys out there, but it doesn't do anything to protect the patient from me, the person in the space with the patient. That's what a privacy blanket does. It helps provide a layer of privacy between the caregiver and the patient we're doing the skill on. Good? But it also helps with warmth. And warmth is really important when it comes to healthcare. We don't really think about this too much, but this room is cold. You guys all think this room is cold. I don't think this room is that cold. And that's because most times I'm up moving around, I'm talking, I'm active. So my body heat is being generated, and that's going to affect how I feel the temperature in here. Make sense? Good? Okay, so in a clinical setting, you are fully clothed. You are running around like a chicken with your head cut off. You are generating a ton of body heat. What is that temperature going to feel like in there for you? Hot. Your patient, however, is laying in bed, not active at all. They are in a thin hospital gown, covered by a thin sheet. What does the temperature feel like to them? Cold. Now take that sheet away. So not only are they going to feel exposed, but they're also going to feel cold. That's why a privacy blanket is used. We always have to think about things from our patient's point of view, not ours. Make sense? Okay. So privacy curtains are not enough for privacy. We're also going to use a blanket. We're going to use this blanket anytime the patient is uncovered or undressed. So we're changing this patient's clothes. They need a privacy blanket because they're going to be undressed. If I'm going to uncover them to do exercises, I would need a privacy blanket. If I'm going to uncover them to wash their body, they need a privacy blanket. So anytime the patient is uncovered or undressed, we need to give them something extra. Good? Make sense? This is something you have to know. It's not going to be on the care plan. The care plan is not going to tell you, use a barrier, use a privacy blanket. You have to know this. Questions? All right, this step just ensures the patient is always covered with something, and we've got a checkpoint for this. It says minimize exposure of resident. So it's important that we understand the issues here with privacy blanket. All right, when we're putting the blanket on the patient, there's a special way we have to do this. You can't do what you do at home. Now, when I'm changing my sheets at home, I take the clean sheet and I do something like this. All right, you guys all do that at home too, right? To get the sheets spread out. Okay. The problem with that, there's two problems. The first is when I'm snapping this, there's a patient in the bed and I'm liable to whip the patient with this. And that can hurt. Anybody ever been snapped by a towel? That can hurt. So that's a problem, right? A wrist injury. But the other problem with this is when I do this, do you guys see the little things that come up here, right? Little like dust things, right? Okay, those are dead skin cells, yeast, and bacteria that this patient has shed. And I'm bringing them, when I snap, it creates a vortex. I bring that right up here where I can breathe them right in. Now, you do this at home and you're only breathing in your own funk. It's not a big deal. But you do this in a clinical setting, you are breathing in somebody else's funk. And that is kind of a big deal because remember, these are doorways. Make sense? So when we put a privacy blanket on, we do not snap or shake that blanket. We get our blanket. Okay, we get our blanket. We unfold it. We don't snap it. We don't shake it. We just unfold it and we lay it down over the sheet. I never want this patient uncovered. So if I take that sheet all the way away and then put the blanket on, my patient was uncovered. I don't want that. So I lay the blanket down over the sheet and then I pull the sheet down underneath the blanket. And when I do that, the patient was never uncovered. Make sense? Now at the end of the skill, when I'm ready to finish, I'm going to pull that sheet up and then take the blanket away. And again, your patient is never uncovered. Now, anything you take off of a bed, we have to roll into a ball so that I don't have trailing edges. If I just pull this off and I've got these trailing edges, anything that I go over is going to spread pathogens. I want this consolidated so I don't spread pathogens around. Make sense? Good? All right. When you have to take the privacy blanket off, so we've used a privacy blanket. We put it on over the sheet. We pulled the sheet down. We did our skill. We're all done with the skill. If we wore gloves for the skill, if we had to wear gloves, wait until after you take those gloves off before you remove the privacy blanket because I've got to pull that sheet up. That sheet's going to go right up next to her face. I don't want soiled gloves touching the sheet that's going to go right up next to her doorways. Make sense? Good? All right. Because that's really gross. Okay, so now we've got another principle out of the way. So far, we've learned skill rules. We've learned the opening. We've learned glove rules. We've learned barrier. We've learned privacy blanket. And we've learned the closing. So out of the 11, we've already got 6 down. We have 1 more to go. And we're not going to do the whole one for this. I'm going to leave a couple of things out until later on in the program. And most of what I'm going to tell you for linen rules, we already know they're repeats. Okay? So linen rules becomes really easy to learn. Page 86 goes over linen rules. This is going to apply to most skills. You can see all of the skills that this principle applies to on that page. Our notes are going to be on page 87. Remember, I take notes for you. So here is our first linen rule. Linens must not touch uniform. Well, we've already learned that with barrier rules. You guys remember that? You can't hold stuff next to your uniform. You have to have clean hands to get your linens. Well, we already know that one too, because we learned that with barrier rules. You can't snap or shake linens. Oh, we heard that too with privacy blanket. So these we already know. So why are they repeated? They're repeated because they have to do with infection control. And infection control is counted really strongly on the state exam. So these are rules you do not want to violate on the exam. Anything that has to do with infection control puts your patient at risk. And what are they focused on the test? The patient. That's right. Make sense? Good? Okay, so we're going to skip the next 2 for right now. Okay, we're going to skip the next 2 little areas for right now and go to the very bottom one. Anything unused must be discarded. So what that means is if I take a whole bunch of linens into my patient's room and I don't use them all, I can't leave them in there for later. I can't use them on another person, and I can't put them back in clean linen storage. I can't do any of those things. So let's talk about why for each one. Number 1, you can't leave items in a patient's room outside of your site and consider them clean. So let's say that I've got some extra washcloths I didn't use. I put them in the patient's chair. I'm just going to leave them there and use them later when I come back to give the patient a partial bed bath later on this shift. They're in the patient's room. Patient's wife comes in, trips over the patient's oxygen tubing, and spills some coffee on the floor. Not a lot, not a big deal, just a little coffee. She wants to clean it up. So she looks in the chair, she sees the washcloth. She grabs a washcloth and she cleans up the coffee off the floor. Great job, thank you very much. But we don't have hampers in the patient's room. We don't keep dirty things in the patient's room. So she now has a washcloth that's been on the floor and has coffee on it and nowhere to put it. So she folds it back up and puts it on her stack of washcloths. And we come in later and we use those washcloths, not realizing that they were used on the floor. And we're going to use that to clean our patient. That's a problem. Anything that's been outside of your vision cannot be considered clean. You can't use anything that's gone into a patient's room on another patient. So you use it or you lose it. Make sense? You will have a written test question on that. They want to make sure you understand that. Okay? Do not ever return anything. If you go into your clean supply room and you take stuff out, don't ever take things back in there. That is like a one-way trip only. Okay? So yeah, items out of your sight can't be considered clean. Any questions on linen rules? Okay, so we're going to take all of these principles and we're going to combine them with our test-specific, our skill-specific steps. So let's learn those skill-specific steps, okay? We're going to, these skill-specific steps are what's going to fill in the rest of these. So if you look at this, right? These we got with our opening. Remember, anything green is our opening. These checkpoints we got with our closing. These checkpoints we got with linen rules. This one we got with scoot and roll. This one is our privacy blanket. So we use those principles to get all of these checkpoints already. So before we ever even start dressing the patient, we've gotten half of our checklist filled in. Isn't that cool? Isn't that cool? So now we just have to learn these steps to be able to finish this skill. All right. So if page 98 is our notes on this. So we're going to ask what our patient wants to wear. Patients have the right to choose their own clothing. They absolutely have that right. So Mr. Jones, what do you want to wear today? Now, I know it has to be a long sleeve, snap or button front shirt. Yes, I know that. But Mr. Jones, what do you want to wear today? Because he gets to choose which long sleeve, button or snap front shirt. Good? It is a graded checkpoint. You must ask. Even though it's a mannequin, we're still going to ask. The evaluator will play the voice of the mannequin for us. Now, sometimes your patients will describe an outfit that does not go together. I want my purple plaid pants and my yellow daisy shirt. And you're like, oh no, it does not match. You are judged by how your patient looks. You are. When family comes in, if mom isn't dressed well, they're going to consider you a bad CNA. Right? You are judged. Your care is judged by how your patient looks. Now, if the patient is asking for this outfit and you're like, oh, that does not go together, you can suggest an alternative. You can say, you know, your white shirt would go really nice with those pants. Do you want to try that? And most of the time, they're going to say, oh, yeah, that's what I meant, because they want to look good. Sometimes they'll say, no, I want my yellow daisy shirt, because maybe it's bingo day and that's their lucky shirt. I don't know. Maybe their son bought the shirt and the daughter bought the pants and they're both visiting today. I don't know. If they want that, they'll get that, but we can suggest an alternative. We'll ultimately honor their wishes, but you can suggest something so that they look good. Does that make sense? Okay. You want to minimize exposure. We're going to do that with a privacy blanket. You should never have a patient that looks like this. You should never have a patient that looks like this. We're missing something there. Good. That's a graded checkpoint. We're going to minimize exposure 3 different ways. Yes, we're going to use a privacy blanket. We've talked about that. And yes, we're going to use a privacy curtain. We do that at the beginning of every skill. But we're going to structure this skill so that we are getting their clothing before we uncover them. What you don't want to do is get the privacy blanket on, pull the sheet down, have them completely uncovered, and then say, oh yeah, or get them undressed, take all of their clothes off, and then say, what do you want to wear? We don't want our patient undressed any longer than they absolutely have to be. Remember, they're vulnerable. Does this make sense? So we're going to protect privacy 3 different ways: privacy curtain, privacy blanket, and getting clothes before we undress them. When you lift any body part for any reason, for any skill, if you're lifting something, you do not lift from above. We're not the claw machine at Walmart. I'm not going to grab something and there's no prize here. Anytime we lift, it's from below with a flat palm. When you lift from below, you're providing support. That arm cannot fall out of my, it can't slip. If I'm doing this, it can easily slip. And now my patient's injured. Always from below, supporting at the joints. Okay, good. Okay, now let's get into skills. Let's get into the dressing a weak arm specific things. So if we have a patient who has a weak arm, you guys remember which arm was weak on the care plan? The right arm is weak. That's right. So in the back of my mind, I know that right arm is weak, and I'm going to use this to tell me how to dress the patient. So we undress strong arm first. USA first. Undress strong arm first. So if this patient has a weak right arm, which arm am I undressing first? Which is the left arm. Now, when I do that, okay, so let's say that my patient has a gown on. This is their weak arm. The right arm is weak. So I'm just going to leave it down here because it's weak. Undressing the strong arm first makes it pull itself out of the sleeve. And then the garment just falls right off that weak arm. No movement necessary. We undress the strong arm first to make it do the work. And then the garment just slides off the weak side. Good? Make sense? Then we're going to dress the weak arm first. So this is my strong arm. I'm going to put the new garment on this arm. No movement required. It just slides right up. It just lays there. Doesn't have to do anything. Slides right up. And then I make this arm do all the acrobatics it's going to need to do to get in that sleeve. Okay. Good. Make sense? I don't want this arm to move. It's the weak one. So undress strong arm first, dress weak arm first. Be careful. Don't cause injury. Be gentle with your patients. Be gentle. That's actually a graded checkpoint. Be gentle. It's a graded checkpoint, which means that people weren't being gentle. Be gentle. All right. Your care is judged by how your patient looks. So make sure everything is lined up right. Make sure the buttons are lined up right, or the snaps. Make sure everything is situated appropriately. The pants are over the butt. The toe seams are lined up over the toes. Make sure they look good at the end, because let me tell you, if my mom is in a nursing home and I go in to see her and her hair is sticking up all over the place and she's wearing mismatched clothes, her socks don't match, they're put on sideways, so they're like, they're scrunched down, the pants aren't even over her butt. Do I think that I'm getting my money's worth, what I'm paying for this? All right. So something that you need to understand is that healthcare is expensive. And long-term care is not paid for by insurance. So if your patient is in a nursing home, they are paying for that out of their pocket. Anybody have any guesses how much a nursing home costs every month? Any ideas? If you had to go into a nursing home, how much it would cost every month?
I work at assisted living, and it's about, go by 7,500.
Yes. Yeah, that's for assisted living. Yes.
Nursing home would be more than that.
Yes, between $9,000 and $12,000 a month out of their pocket. How many of you guys have an extra $9,000 in your budget every month? I don't even have $9,000 in my budget per month, period. Not even an extra $9,000. Families have to pay for that.
Well, in my case, like the diapers and, everything.
Right, plus the supplies. That's minimum. That's minimum. Absolutely.
And they monitor is $750 for monitoring the room.
Yes.
Plus all the, all the toilet and stuff.
Yep. It's expensive. Now, so let's say that we paid $9,000 a month for mom to have a place in a nursing home, and you come in and see her like that. Like you are going without food to afford mom's medical care, and you walk in and her hair is sticking up and her socks don't match. And how are you going to act? I'm going to be showing stuff, right? Like I have to give up money for somebody to take care of mom, and you aren't even doing your job. Oh, good luck to you, because we're going to go at it. This counts, people. The way that you present your patients counts. You will be judged by how your patients look. So take a minute. Make sure they look good. Don't end your skill until they look good. Now, remember our care plan said we're going to leave our patient in bed. Okay. So they're going to end here. That's where our scene ends. They're going to stay in bed. Now, the head of the bed, we're going to put it up to put their shirt on, just because it's easier to dress somebody, you know, put their shirt on with them sitting. So we're going to put the head of the bed up to put their shirt on. At the end of the skill, it's whatever they want. Do you want the head of the bed to stay up? Do you want it down? What do you want? We're good for you, whatever you need. Okay, we're going to offer, but you don't have, it doesn't have to be down. They're dressed. They're probably not going back to sleep. How many of you guys get up, get completely dressed, and then lay down and go back to sleep in the bed? Doesn't really happen, right? So if they're awake and dressed, it's perfectly okay to leave the head of the bed up. They're probably going to watch TV, do a crossword, visit with family. Good? Makes sense? Okay. So we've taken the patient's gown off because we got them dressed. We also had a privacy blanket that we used. Those items have to go into a hamper, not on the floor. Nothing goes on the floor but shoes, ever. Nothing goes on the floor but shoes. You're going to hear me say that a lot. So we don't throw the privacy blanket on the floor. We don't throw the dirty gown on the floor. Nothing goes on the floor but shoes. Good? Good. All right. When we are done with the skill and we're doing our closing, thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Environment's clean, bed's in the low position. I'm going to open the curtain and give you your call light. This is important. That call light must go in the patient's stronger hand. Do not put that call light on the weak side. It's weak. Make sense? This is a graded checkpoint, and it's an important one because your patients always have to have a way of calling you if they need you. Questions? All right, so now we know everything we need to know to do this skill. We know to follow the care plan, to do the opening. We know to evaluate if we need gloves. By the way, for this skill, you're doing this on a patient. She's holding, or on a mannequin. She's holding on to all of her own body fluid. She has no wounds. We're not anywhere near her personal skin. So for the test, you don't need gloves. We're going to use a barrier on the table. We're going to use a privacy blanket. Linen rules apply. We're going to use all of those steps we just went over. And we're going to do the closing. We're going to put all of that together and make a skill out of it. Now remember, at the very beginning, I said that you have 14 minutes to do this skill. You're just getting them dressed. It doesn't take 14 minutes. Don't rush this, okay? Don't rush. So here is our checklist for this, and we're going to use these principles to check off those checklists. So we're going to follow the care plan, which tells us to dress the resident by putting on pants, shirt with sleeves, and socks. So we're going to follow that care plan. We are going to do our opening and get all of those check marks. We're going to evaluate if we need gloves, but we won't for the test. We're going to use a barrier to provide a clean place for our supplies. And we're going to use a privacy blanket to minimize exposure. We're going to get our linens and make sure we're not holding them up next to us when we get what we need. And make sure we don't put anything on the floor. And we're going to do our skill-specific steps. Remember, we lift from below, we ask about clothing preference, we get our clothing before we undress. We undress strong arm first and dress weak arm first, make sure they look good at the end, and the call light goes in the stronger hand. This care, oh, I'm sorry. And then we're going to do our closing. This care plan is only for this patient. This patient probably has a different care plan. He gets himself ready. We don't dress him. He does that himself. He doesn't need us for that. This guy needs a little bit of help, but he just needs verbal help. He needs somebody to remind him of the steps. He does the work. We just tell him, hey, put your knickers on, get your socks on, pull your pants up, go ahead and button and zip them, and let's get your shirt on. Okay, so sometimes we just need some verbal reminders. This lady here, she needs a little bit of help getting dressed, but she doesn't have a weak arm. This one is the one with a weak arm. So her care plan is different. You guys see how everybody's care plan is going to be a little different? Good? Makes sense? All right, so I'm going to show you the video for this. Remember, at the bottom of the video, you can actually see the checkpoints for the test that are being checked off as I'm doing the step. Okay? Can you tap her, please? Okay. Yep. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I'd like to get you dressed for the day. Is that okay? Very good. Let me close your curtain, wash my hands, get my supplies, and I'll be right back. After washing my hands, I'll gather my supplies. We'll start with a barrier, and then we'll ask the patient what they want to wear today. Mrs. Jones, what would you like to wear today? We'll get the outfit the patient described, including a pair of pants, a long sleeve button or snap front shirt, and a pair of socks, as well as a privacy blanket. Okay, Miss Jones, I've gathered our supplies here. So we're going to start with a privacy blanket. I'm going to lay this blanket out over you. This is going to help keep you warm and protect your privacy as we do this skill. I'm going to be careful not to snap or shake the blanket. We'll put it right over the sheet and pull the sheet down underneath. And we're going to pull that sheet all the way to the end of the bed. Okay, we're going to start with the socks. I'm going to take the first sock, scrunch it all the way up to the toe seam, and place it on the foot so the toe seam is lined up over the toes. And then I'm going to lift the leg from below and pull the sock over the heel gently. We want to smooth it out, making sure there's no wrinkles and the heel is in the heel place. We're going to do the same thing with the other side. Scrunch it up, put it on so that the toe seam is across the toes. We'll lift from below with a flat palm, put it over the heel, and smooth out all wrinkles. Okay, so now we're going to put your pants on. I'm going to unfold the pants and scrunch up the leg all the way to the end. And I'll put my hand in through backwards. I'm going to hold the foot to slide the pant leg over the foot, and then I'll lift from below to slide the pant leg over the heel. We'll repeat on the other side. So we're going to scrunch the pant leg up all the way to the end. Put our hand through and hold the foot in place with our hand while we slide the pant over the foot. Lift from below to put the pant leg over the heel. And then we're going to pull the pants up. Okay, Miss Jones, if I can have you lift your hips up for me. Very good. We'll pull the blanket down and straighten the legs. Because we have to undress the strong arm first, and your care plan indicated that your right arm was your weaker arm, I'm going to sit the head of the bed up to make this a little bit easier to get you dressed, and we'll undress your left arm first. So I'm just going to press the button to get you into a sitting or semi-reclining position. This makes it a little bit easier for dressing. And I'm going to help you sit forward by putting my hand on your upper back. And on the count of 3, you're going to sit forward. 1, 2, 3. Thank you very much. I'll hold you in place, untie that gown, and then we'll tuck that privacy blanket behind your back as we return you to a sitting position. We're going to remove the gown from this arm, supporting at the elbow as we lift, and then resting the elbow back on the bed. We'll move the gown to the other side. Okay, so we're going to remove the gown from your weaker arm now. So again, I'll tuck a corner of this blanket behind you. We're going to remove the gown from the weaker arm by lifting from below at the elbow to extend the elbow out very gently, minimizing motion. Then we'll rest it back on the bed. The gown will be put on the overbed table. Now we'll take the shirt, and our care plan specified a long sleeve, snap, or button front shirt. This is a snap front. So I'm going to take the sleeve and bunch it up, putting my hand in through backwards, and hold the patient's hand, holding all the fingers together, keeping the elbow on the bed as I slide the sleeve over my hand and the patient's. Then we'll lift from below at the elbow, supporting, and slide the arm sleeve all the way up. We'll rest that elbow back on the bed. Mrs. Jones, if I can assist you to sit forward, I'll put this shirt behind you around to the other side. Ready? 1, 2, 3. Thank you. We'll support at the upper back as we assist her. We want to smooth that shirt down. Come on back, Miss Jones. And I'll go to the other side to finish getting you dressed. And I'll help you put your arm in this sleeve. Again, we'll scrunch the sleeve all the way up, put our hand in through backwards, and this time, Miss Jones, if you can reach your arm back and grasp my hand. Thank you. Support at the elbow. And then we'll snap the shirt, making sure that the buttons are aligned properly and everything looks good. Now we'll remove the privacy blanket. Adjust your clothing for neatness and appearance. We'll wind the privacy blanket up in a ball, and I'm going to go get your gown, and we'll put these in dirty linen, and I'll be back to get you all settled. These items will go in dirty linen. I'm going to throw your barrier away. Ms. Jones, is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Would you like the head of the bed adjusted at all? Or your sheet back on? You're good like you are? Wonderful. Here's your call light. We're going to place it directly in the stronger hand. If you need anything, please press that red button and we'll be happy to assist you. Your bed is in the low position. The environment is clean. I'm going to open the curtain, go wash my hands, and if you need anything at all, please feel free to call. After washing my hands, I'll review the care plan to make sure that I undress the strong arm first and dress the weak arm first and put the call light in the stronger hand. I'll make any corrections that I need to make and then tell the evaluator my skill is done. You can just have a seat wherever. All right, any questions on that?
The blanket, the sheet, that
Okay.
was at the end, you didn't need to bring it back up.
So remember, the patient has to be covered or dressed at the end. Since we dress them, there's no need for the sheet. You can ask if they would like it, but generally speaking, for the most part, if somebody's dressed, the sheet, I mean, they're covered, so the sheet isn't needed. Okay. All right. Remember that we do have flashcards available, and they are $14.99 while you're enrolled in the program. No, that's next class. Thank you. All right, so we're going to move on to the last skill for today. This is going to be on page 76. I'm so excited we're getting to this one today. Normally I go too long. All right, so this is range of motion. This is a super quick skill. If you look down here, somebody with your level of experience, which is none, should be able to do this skill in 4 minutes or less. So super fast skill. Okay, this is going to be done on another testing student. That person will be positioned in a bed. Documentation is not required. Down here, you'll see all of the principles involved. Oops, they're spelled out for us here. We do need to learn these, which are specific to the skill, but we know skill rules. We follow the care plan. We know to do the opening. We know to evaluate if we need gloves, and we know to do the closing. So we know all of those things. So what we need to learn is this. If you look on page 77, we have our care plan at the top of the page and step-by-step instructions. There are no supplies necessary for this skill. And let's take a look at the care plan. It says, now don't panic about the words on the care plan. I'm going to explain them all in just a minute. But it says, provide the following range of motion exercise to the resident's left shoulder: flexion, extension, and abduction, adduction. Provide 3 repetitions of each exercise, and the resident is not able to help with the exercises. Now, I know those are big words. We're going to explain those words in just a minute, but this is our care plan. So we're going to do 2 exercises to the left shoulder 3 times each. That's what we're going to do. And we have 4 minutes to get that done. But before I show you how to do range of motion, we kind of have to learn a little bit about what range of motion actually is. And in healthcare, when we think about exercises, we tend to think about this, right? Exercises that make something better, that improve function. We have a whole department for that. We have a whole department that regains function. That's not us. Physical therapists have to have a doctorate degree, 10 to 12 years of education. We're here 4 weeks. That is not us. What CNAs do exercises for is to retain function, to keep what they have, to keep it from degrading while they're going through other treatment. We're just trying to maintain. Does that make sense? We're not trying to make anything better. So if the patient says, ow, the next repetition goes below the ow. We don't want ow. We don't do ow. That's not us. That's them, not us. So if we have flexion extension, which is an up-down motion, and the patient gets to here and says ow, then the next repetition would go below the ow. And we would let the nurse know, because that's an observation, the patient had pain. Make sense? Good? Okay. So we have to know our role. So there's two different types of range of motion. There's active and there's passive. Active means the patient did the exercise themselves. We just told them what to do and monitored to make sure it was done right. Passive range of motion means that we do the exercises on the patient. Now, this care plan says the patient's not able to assist with exercises, so we're doing passive range of motion. But sometimes CNAs will be asked to do active. 10 repetitions, flexion extension of the left shoulder, just make sure that the patient does them. Okay. Most of the time, those CNAs are responsible for passive range of motion. So these are the principles involved. We have skill rules. We're going to follow that care plan. We're going to do our opening. We're going to monitor to see if we need gloves. Spoiler alert, for the test, you won't. And we're going to do our closing. Questions so far? All right, here are our skill-specific steps. Let's get into these. So we're going to always, when we lift an extremity, we support from below. We've already learned this. Okay, so we support from below near the joints. This is a graded checkpoint. Always support from below. So we're going to lift with a flat palm, not a claw. This is a graded checkpoint. We're going to go, when we do exercises, there are two halves of an exercise. And I'm going to explain this in just a second. But one half gets us somewhere, the other half gets us back to start. You always have to go back to start. Otherwise, it's not a full range of motion. So let me explain what I mean. If we have flexion extension of the left shoulder, that's an up-down motion, okay? So extending the arm up and flexing the arm back down, okay? Two halves, one exercise. Make sense? This gets us up and this gets us back. Questions? Okay, so if we are doing this, we have to have a full range of motion. So all the way up and then all the way back to start. I can't get to here and go back up. This is not a full range of motion. It has to go all the way back to start. Make sense? Okay. So we're going to move slowly and smoothly all the way back to start. So I can't do this. Right? Slowly and smoothly supported all the way back to start. We're going to do as many repetitions as the care plan tells us to. We're going to look at that care plan again in a minute. Flexion extension is up, down. Remember, there are two halves of one exercise. So if I asked you to extend your arm above your head like you're asking a question, you would do this. This is extension. We know what extend means. Extension. Flexion is to bring it back. Okay, good. All right, and then we have abduction, adduction. When you abduct a child, you take it away from its family. Don't do that. That's bad. We don't abduct. But we do abduct extremities. When we abduct an extremity, we take it away from its family. Adduct, remember, two halves of the same exercise. So adduct brings it back. So abduct takes it away. Adduct brings it back. Okay, good. Good. Then there's one more exercise that CNAs can do. It's not on the state exam. You will not be asked to do this on the state exam. But the last exercise that CNAs are allowed to do is rotation. Now, rotation is just one motion because you end where you start. It's all the way around, all the way around. Remember, flexion, extension had two to bring you back to start. This is just one exercise to bring you back to start. Now, not all joints move in all directions. Your wrist does. Your wrist goes up and down. Your wrist goes side to side. Your wrist goes around. The wrist does all. Shoulders will do all. Shoulders can go up and down. Shoulders can go side to side, and shoulders can go around. Your elbow does not. Your elbow just goes up and down. If you get an elbow to do anything other than this, you broke it. So we follow the care plan. The care plan is going to tell us what body part, what exercises, and how many repetitions. And we're just going to follow that. Good? Now, as we're doing that, we want to be monitoring for pain. I'm looking at the face. I'm looking for any wincing, any grimacing, any turning it away. I'm feeling the extremity. Are they resisting at all? I'm monitoring for any signs of pain. I'm also going to be listening to the patient. Are they, breathing in? Are they breathing rapid? Are they making ow sounds? So I want to make sure that I'm monitoring for pain. I don't want to inflict pain on the patient, not my job. Make sense? Good? Good. All right. So when you're looking at a care plan for range of motion, there's 3 things we need to know. We need to know which joints we're exercising. We need to know which exercises we're doing and how many repetitions. We're just going to follow that care plan. Any questions on that so far? So we're going to use all of these principles to check off our checklist. So we're going to follow the care plan. We're going to do our opening and get all of those check marks. We're going to evaluate if we need gloves to get that check mark. We're going to do our skills-specific steps, and then we're going to do our closing. And if I do all of those things, I'm going to get 100% on the exam. Questions? This care plan is only for this person. These other people, they have different care plans. This one is just for this guy. So Jake, if you can show us the video for passive range of motion, this is literally a 2-minute video. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some range of motion exercises on your left shoulder. Is that okay?
Yeah.
Let me close your privacy curtain and wash my hands. I'll be right back. Okay, Mr. Jones, the first exercise I'm going to do is bring your arm above your head and back down to the bed like you're asking a question. I'll do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay?
Okay.
So we're going to bring your arm all the way up, supporting at both joints. Slowly and smoothly, all the way back to start. Here's 1. We're going to do that 2 more times. Up, still okay?
Yes.
Back to the bed, and 1 more. Up, and back to the bed. Okay. The next exercise we're going to do is bring your arm out and back in like you're making a snow angel. Okay?
Okay.
So I'm going to support at 2 joints. We're going to go all the way up and all the way back to start. Feel okay?
Yes.
All the way up and all the way back to start. Still okay?
Yes.
1 more. All the way up and all the way back to start. Good?
Yes, ma'am.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. Bed is in the low position. Let me give you your call light. Here's your call light. If you need anything at all, just press that red button. We'll be happy to help.
Thank you.
I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right. Okay, so over the weekend, you have 2 chapters of homework to read. You're going to read chapters 2 and 3 in your yellow book. You're going to take the tests on page 182 and 183 of the white book and grade them. The after class wrap up emails have already gone out, so you can review that. If you're not getting the emails, please let us know. Jake already passed out your review sheets. If you're attending virtually, please remember those review sheets are available for you as well on flcnatraining.com. Okay, that wraps up today. Have a great weekend. Get some rest. Do something fun. It's not all about homework, but these are long chapters, so you probably want to get started on them sooner rather than later because it's going to take you some time to get through them. Okay? All right. Until next time, happy caregiving. Thanks for joining. Bye.